presenting the case. Okay, so let me start with the review of the case or the presentation. So can we move to the next slide? Is a 26-year-old male with typical vasovagal syncope since the childhood. He had recurrent episodes with quite high frequency of 1 to 6 per year. His conservative treatment was ineffective. He has some comorbidities, but he's otherwise healthy at his age. Can we move to the next slide? He has normal ECG, normal echocardiography. On tilt test, he had mixed syncope after 2 minutes in upright position, and he was junctional rhythm followed by sinus arrest lasting for 9 seconds. Carotid massage was negative. Can we go for the next slide? This is the change of the frequency of the sinus node with the 66 beats per minute going to 126 beats per minute. So quite pronounced, I would say, change, and presenting a vagal innervation. So what is scheduled for today? We already started in the morning. It's a cardioneuroablation in general anesthesia, right-sided ablation only with thermocool smart touch catheter, 3D navigation guided by the CT, and we may use the extra cardiac vagal nerve depending how it goes as a kind of measure of the outcome test. And obviously, because of the junctional beats, the point here is to have a sinus node denervation. So I just maybe describe what was done in this morning. So we start in general anesthesia. We put 2 catheters in the right groin to one is CS, one is for the ablation. We also put this one extra on the left just to have this possibility to do the jugular pacing. And we created a 3D geometry. We mapped and hopefully you can see the cardio map. We used CT merged with the map. We mapped the sinus node, which is the region that you would expect. So it's the red kind of cluster of points, and the black dots generally stayed when we had a phrenic nerve capture. And so this is the setup, pretty straightforward. And maybe you can comment on what's the plan the next, or the anatomical approach.
And as you can see as well, Inge has designed a white line on the picture. This will be our target line. So we will deliver radiofrequency application along that line, and we will take the response into account to eventually a little bit accommodate the lesions set. Importantly, when we have to realize that when we deliver a radiofrequency application on this side, what we see is the result of vagolysis, but we can also have autosympathetic stimulation if we are stimulating axons from the autosympathetic nervous system. But the heart rate acceleration coming from this stimulation tends to vanish, while the other heart rate acceleration had another curve, really typical sigmoidal curves, and tend to remain. So I think it's possible to differentiate the two, but we have to realize that potentially when we do this ablation, we see heart rate modifications. What we see is the results of both things. That's so the plan is actually to deliver radiofrequency application along this line. So we are performing now. To come back to the comment of the previous speaker, we are performing a randomized trial, sham control randomized trial, double-blinded, and in this trial, the endpoint of the procedure is when we reach a stable heart rate acceleration with a PP interval of less than 550 milliseconds with at least 3 applications, we stop. If we have 70% heart rate, the shortening of the PP interval, and it's stable after 5 minutes, we may stop. If we have the impression that we have reached the maximum effect, we may stop. And the maximum lesion that we are delivering in this trial is 10. So maybe we could follow the same rules for this procedure, and then see what we achieve. But also importantly, we ask the anesthesiologist to deliver medication, remifentanil, other drugs to maintain the drugs, avoid any stimuli to create a high vagal status, pharmacology induced to unmask this vagolysis. So this is for the setup, I would say. Is it ablation, Peter?
Můžeme, která je tady ta placka ablační nebo padel ablační, který by šel použít? The other way is just to tell you can tell where you want it. Maybe you can comment on the sites, how you use the CT and select the site for ablation.
So regarding the CT. So regarding the CT, when as I showed this morning, we look at the interaction between the right and left structure, and then Ingrid, who is managing the Carter system, set this line offline based on the CT, and this white line is solely projected on the electroanatomical map, but has been designed before the procedure started. So this is actually
this should do the ablation.
So if you
what is the parameter you want to set?
40 watts.
40 watts, nastavíme tam 40 W.
So also as I said this morning, as we are performing a unilateral procedure, and that we need a deep lesion on the epicardial space, we use higher ablation index than people performing bilateral ablation. We use typically an ablation index of 800. So it's much more than that people are usually doing. Beside this, we follow, of course, the cycle length. We have, like always, to stabilize the catheter there, and the rest is common practice, I would say. I don't know if there are additional questions, or if we may perform the first application of radio frequency energy. There's no.
We don't. Is there a question for us? Because no, there's probably
there
not.
Is one question. There is one question.
It was just the other room.
There is transmission or not?
Yeah.
Peter, hi, it's Alan. Have you tested extravagal stimulation prior to the lesion, the first ablation?
To be honest, we did it just to see for our purposes. So generally, in the very beginning, we introduced the catheter in the jugular vein.
Okay.
And there was this pause with during the this is sinus, and if we go for the next one, which will be during atrial pacing, there is a pronounced kind of response. This is physiologic. This is not this is something everybody in the room probably would have.
So you did it
if you have this pacing in the
You did it
vein.
at the beginning of the procedure just for our purpose? No, this is not part of
just having the kind of baseline.
Yeah.
But this is not part of this kind of protocol of doing it. We just wanted to kind of have a comparison, and we hopefully do it at the end of this just to see what is done. But aim is not to guide this procedure by this extracardiac jugular pacing or stimulation.
Yes.
This is to stimulate the discussion. But we also determined the Wenckebach point before procedure, and we just did it, and it was 440 milliseconds at baseline.
I believe it was higher. It was 500.
Excuse me, 540
milliseconds. So quite low, so already quite high vagal status. So it's just 111 beats per minute is one-to-one.
I think we did some study showing that Wenckebach point is not a really reliable measure for this denervation, so it's just some kind of surrogate which is not very accurate. So I have a question. I'm sorry that I was late because I had to implant some leadless and we had some problems. I was a bit delayed, but I could not hear some lectures, but I can ask Michel Brignol, do we need randomized trial if we have clear endpoint, if we have really you know, we denervate the heart. It's not like a renal denervation. It's true endpoint. So, and symptomatic, severely symptomatic patient, then we have no problems afterwards, and we know that we did reach the endpoint. So, is there still need for at every price to show it in randomized trial? Yeah. What is your opinion? We are discussing all the time.
I'm not sure to have understood what you ask. You say we need acute endpoint for randomized trial.
No, we know that we do reach this denervation during the procedure. We have clear procedural endpoint, and we have clear benefit. I know you can tell me that this is a placebo effect, but so, or do we need a randomized trial comparing with pacing, or what kind of trial you would recommend to have?
I have already said something at this regard. The optimum would be to have a clear, defined endpoint during the procedure.
That's what we have.
But listening to the speech, the lecture of Dan, for example, this morning, and of Piotr, I have realized that it is probably very difficult, impossible. So, or very difficult now. We still do not know. So, what is my solution? Is to define success, clinical success, and then to go back to the electrophysiological parameters in order to identify those who predict the best outcome. So this is a solution in order to solve this problem. What is, we need to define success. And we can define success in two ways. One is recurrent syncope. Mm-hmm. For this, we need a longer follow-up, minimum 2 years. The second possibility, in order to shorten the follow-up period, is to implant a loop recorder before the procedure, maintaining after procedure, and to perform the procedure only after that the loop recorder have documented some events, in order to compare events before and after. This is the protocol that is ongoing in Italy. It's called Italian CNA. Mm-hmm. This is my opinion.
Thank you for, because there are always different opinions, so I would like to hear your opinion. So, guys, let's continue. I'm sorry to interrupt, but this is important, I think, for future of this procedure, because there is a lot of people who don't believe, and they argue all the time that we have no data. So I think we need to clarify how to proceed.
30 is okay. That's fine. Okay, it's 30 is fine. So if you're ready, you can start the blade.
So the catheter is in position. Is placed. Is facing this target line, and the basal cycle length is currently 1024 milliseconds. So if we agree, we will start the ablation.
Hold on. Just
is it connected? Or maybe it's the
we
pacing
have some
selected?
technical. No, we have to. So just hold on. There's some connection. We have to check.
The patch is connected?
Yeah. Just they just have to switch and. So there was an error of the indifferent patch is not connected. So it was connected, but maybe there's some. The impedance was there, so there was a connection, but maybe it was too high, or I don't know. So let's.
May
we tried. Can we try again? Can you maybe try again? Mm-hmm. No. So hold on. Sorry for this.
The
No. Just hold on. It's connected, but there's maybe some. You need to reconnect or. But there was already we had an impedance, so that I don't know why this happened.
Wait, we still have, huh?
The location is good. Now we have. No, try one more.
Mm-hmm. No. The pacing is not connected, huh? The pacing stimulus is not. No.
Can we try again? No. Stop.
Do we need to
Okay,
change it?
they will just put a new and
New
different
cable or?
new indifferent electrode. Sorry for this, but it was showing the impedance. I don't know what was happening.
Mhm.
Můžeme jednorázovou tu pečku nalepit, někde sehnat.
So you have problem with starting ablation because of impedance?
But the impedance was there, but I don't know why the ablator doesn't want to really deliver. So yesterday we used this Heliostar, which used an engine generator. This morning we have again the smart ablate and maybe some of these connections because of the changing. That's unfortunately the situation. If you keep changing technologies within the lab, that sometimes there might be some unknown things to happen. But I believe that's easily solvable by putting this single-use temporary indifferent patch. Okay, so now we have. Okay, it looks like. So check your position whether you're happy.
Yeah.
You're happy. So try to deliver. Okay, perfect. It works. So that was easy to solve. That's the normal life in EP, that you get changes.
Shit. The catheter is not very stable. I will try to. So look at
The heart rate.
The cycle length.
You see the cycle length in the middle, so it just increased up to 120 beats per minute during this application. The lesion index is reaching 500 now, and the aim is 800.
So I think we can say that the target line was well positioned.
And there is question.
We are listening.
Yeah, few seconds because we need microphone.
Philip, again, thank you. I'd like to ask you, how do you discriminate the denervation effect from the pain effect? Do you measure the depth of the sedation, depth of anesthesia? Because it could be that in some position...
That's why we ask... No, but that's why we ask really a deep anesthesia with remifentanil, increasing
800.
doses, so...
I have an experience that with different anesthesiologists, you know, unless you really measure the depth of the anesthesia by advanced techniques, that you're not really able to discriminate. And that's why I also stress the importance of extracardial vagal stimulation, because this is the clear endpoint, not just accelerating, because you can see after you stop burning and finishing your lesions that the heart rate goes down. And this is the clear surrogate, let's say, point showing that it was not the denervation effect, but it was rather a pain effect. And it differs from anesthesiologist to anesthesiologist, and there are different people attending the labs. So that's my comment against not using extracardiac.
You have to bring your favorite anesthesiologist.
Yeah, but
I fully understand you have the best one on during the workshop, but it's not always the case.
I disagree. I really disagree. So as I said before, the ablation is the result of both orthosympathetic stimulation to axonal stimulation and vagolysis. That's point one. Point two, if you have a deep target, you have the central necrosis and you have also edema, vagolysis, not permanent. And this really explain these typical sigmoidal curves. Look, the cycle length is clearly resetted to another level. It's one application. We had a cycle rate of more than 1,000 milliseconds, and it's now 500 milliseconds. Besides this is not a place where you have a lot of pain. None of these patients, we have treated more than 100 patients, none of them had pain the day after the procedure, not a single one. So I cannot agree with the comment.
So what is procedural endpoint? How much you have to increase the
So we, as I said before, in the randomized study that we are performing now, when we reach a heart rate of 550 milliseconds or lower, with at least 3 applications, we can stop. So I need 2 more. And I will insist on the lower part of the line to have a more pronounced effect, let's hope, on the AV node through the ARGP-IGP pathway. So this is second application. Sometimes you see also that you have orthosympathetic denervation and that the heart rate after additional application tend to decrease. But it's not due to the fact that we have less vagolysis, it's just to the fact that we have less orthosympathetic stimulation of this sinus node, which could be a desirable effect if the resetted heart rate is too high. What I propose is to deliver a third one, and then we can control the anchor back point as well. And if you want, we can ask the gentleman to put the catheter in the jugular vein again and to try to do what you are used to do.
So then in the meantime, we will move to another lab to see.
Yeah. It's
so
yeah.
Can we wait one more application or and go to the other lab, or what do you want to do?
And then
první větu, jo, pak budeš pokračovat.
Okay.
Oh, we have already done? Okay. Tak dané?
Can you? I know that you can see us. Can you hear us as well?
Yes, we can.
Yeah, perfect. So only one sentence for introduction. I'm here with Predrag Stojadinovic, who prepared all the things, all the maps, left atrium, right atrium, phrenic nerve, sinus node activation site, and all the setup, including the cannulation of both jugular veins. And now he will introduce the patient first, and he will describe what he did so far.
Okay. So today we will show you the case of cardioneuroablation in a patient with a pacemaker. Can we show the next slide, please? So this is a 47 years old, otherwise healthy female patient with no structural heart disease. She had a history of recurrent syncopes since she was 19 years old, but in last year in July, she had intensification of her symptoms. She had syncopes twice or 3 times per day, with typical prodromes, and so she went to the emergency room in other hospital here in Prague. It was University Hospital, where they documented the AV block with 7-second pauses, and they did a brain MRI which was normal, and they implanted pacemaker. Actually, this is, I think, really sad, because Dan did more than 200 procedures. He is giving lectures every year on every Czech cardiology and EP congress, and but you see, maybe it's not enough. Dan, you need to be more active. And since the implantation of the pacemaker, she didn't have any syncopes, but the atrial and ventricular pacing was 0%. Okay, let's show the next slide. And this is her ECG on admission, and here I want to show you the previously done atropine test. Base rate was 73, and in 5th minute after the administration of atropine, she had a pretty nice sinus rhythm acceleration up to 111 beats per minute. So the next slide. So this is our plan for today. So this will be the radiofrequency catheter ablation procedure in general anesthesia using CARTO, and this case will be facilitated by ICE and guided by extracardial bilateral vagal nerve stimulation. So the aim of this procedure will be to complete the denervation of the AV node with subsequent SA node denervation as a endpoint, and then will maybe explain you why this sequence is very important in this patient. So next slide. Okay, this is our team. So far, what we did is that we obviously obtained vascular access. We cannulate both jugular veins, internal jugular veins, using a long arrow 80 centimeters sheet. Then we did transeptal puncture. We created an anatomical map of the left atrium, where we annotated the supposed sweet spots for the AV node denervation, which is the purple one. Can you show them on the septum, just in the middle, between the lowest part of the right inferior pulmonary vein and mitral annulus on the septum? And after that, I created this, and we also annotated the sweet spot for the sinus node denervation, which is a, I think, pink point in the left atrium. Okay. And then we created the right atrial map, where we tagged the phrenic nerve, where we had the phrenic nerve capture. We annotated the roof of the left appendage, and because this is right appendage, sorry, and this point is very important, because at this level we can expect on the posterior wall we can expect the sweet spot for the sinus node from the right side. You can correct me if I say anything wrong. Right. And then we did a activation map for to catch the exit of the sinus node, which is this green point, I think, with prematurity of minus 87. Okay, and then we relaxed the patient, and we did bilateral high frequency vagal nerve stimulation on the during the sinus rhythm and during the atrial stimulation. And we can show them the responses maybe now, if you like.
Or we may even repeat. Now the patient is more relaxated, but we had huge problems with achieving a nice vagal response. Can we see fluoro? I will show the position of the catheters.
Live fluoro,
can you see fluoro? Can you switch?
Yeah, I see.
Yeah.
Okay.
All right. So first, I will show you how I manipulate with the catheter inside the right jugular vein, and it is absolutely all right. This position, a little bit more superior to upper molars. This is nice position for a right jugular vein, for a right vagus, and we may do the stimulation just now. And
can we see X-ray?
Like online. And you have to see also the live Bruca. X-ray is not essential just now.
Okay,
just to see the response of, but unfortunately the response is weak. Let's do this in sinus first, and subsequently in faster atrial pacing. So this is stimulation during.
Oh, this is junctional rhythm now. Okay.
And we can't assess sinus pause because there is a relatively active junctional rhythm during the high frequency vagus nerve stimulation. So there.
And that's not uncommon.
This is infrequent, but now there is some change, of course, some vagal response, but it can be assessed. Normally, we achieve 7, 8, 9 seconds pulse sinus arrest. It's not possible here. And let's repeat this during faster. Yeah, if there is, and there was again a very weak AV nodal response.
Now it's going.
Yeah.
Maybe 2 to 1.
Maybe there is too short period of 2 to 1 block at the end of stimulation train. So this is not perfect, far from perfect. But
let's go for the left.
We have to use this like baseline for this procedure, and this is even worse for left vagus, because we were unable after multiple attempts, we were not able. It looks like we are inside internal jugular vein, but it is not true. We check it by contrast agent, and catheter goes all the time to the external jugular, and there is I would like to go more superior. It's not possible because it is external vein, and we have no idea where is the branching internal and external. It's not possible to go there. So unfortunately, we have to avoid left vagus stimulation and rely on these weak responses while right vagus stimulation. All right, and the major problem in this patient is AV nodal disorder. So we will start with denervating of sinus node, and I usually start in left atrium. So I need to see the whole transeptal hole, left atrium only.
You mean you will start with AV node? You said SA node, AV node.
Yeah, exactly. Yeah. Because it is always better to start with the worst condition, okay. And subsequently, in some patients it is enough. In others, there is also need to ablate like superior ganglia, not only for sinus but also for AV nodal denervation. So I go to the bottom of the left atrium just now.
Can you show eyes now, please?
Yeah.
Dan, can I ask you something, Piotr Kurakowski?
Yes.
Oh, you have this very nice view. My question is, if you have problems with the extracardiac vagal stimulation and there is no good response, you can use ultrasound and then identify vagal nerve because it may be the course may be not as usual. That is my first comment. And the second comment, when you showed this sinus rate acceleration after extracardiac vagal stimulation, presumably due to pain, are you not afraid that when repeating many times extracardiac vagal stimulation at the same spot, we are doing some damage to the vagal nerve? What is your opinion?
I think damage is almost impossible because the pulse width of this pacing configuration is very short. So the output is like half a watt at the pacing side. So this is this acceleration is sort of non-specific, like irritation or inhibition of the vagal activity because of this high frequency pacing. But there is no way how to do either nerve damage or jugular vein wall damage. I think it's not likely because the energetic output is very low. And your first question, the first question related to the use of ultrasound to find the true position of phrenic nerve. We have never tried, so I have no experience with this. I know you published the study on it, and it could be maybe we should in this patient it could be useful, of course, but usually vagus nerve can't be displayed at this level, at the very superior level. You should go like more distally or more proximally to the neck because definitely ultrasound prone can't display this very superior position when we normally pace vagus close to the output from the brain. So if it is enough, let's now we are sitting, catheter is sitting at the sweet spot for AV nodal denervation from the aspect of the left atrium. You see the either cartomap and ultrasound. We are at the, let's say, apex of the pyramidal space, and we will give first burn here. So 30 watts, 30 seconds. Of course, there is normal AV conduction. Nothing is visible during delivery. It should be tested subsequently with using the extracardiac vagus nerve stimulation. Unfortunately, again, we don't have left vagus, and we have only big response at right side. And I usually give not only single delivery, but one more here, a blade, just to sort of safety burn. 3 deliveries, 30 seconds each. Dej tam trošku dolejš, ten bod, teď. And I will go again closer to the mitral annulus. So total 90 seconds of RF delivery. So second point and the third. Prosím, odstraň mě ten CS, ať je tam vidět. Tak. A blade here. Now we are more at the base, I think, at the base of the pyramidal space. Maybe not. So I will release catheter slightly to be more there. And I think this is enough. This will be enough. You see also some sort of whitening there. And we of course recheck by by vagus nerve stimulation after this cluster consisting of 3 lesions. So I go to the vein not to create ectopic beats. I will recheck the position of the catheter inside the right jugular vein. It is dislodged and should be positioned back to the side with the maximum, even if say. All right. And now we are interested in AV nodal response only. So we do this in atrial pacing of the same frequency just to be consistent. You see the response is even
bigger.
worse.
Yeah.
It's not infrequent. We had only short episode of 2 to 1 AV block at the baseline, and now what was the pause? 5 seconds, 8 seconds? Oh,
Yeah.
4.5. So again, it may happen, and it is sign of sort of irritation instead of ablation. So we will advance this pyramidal space from the aspect of coronary sinus. Give me please LAO, right atrium, and CS. Just to navigate to, I will go out of the left atrium to the coronary sinus. Hopefully I'm inside. Yeah, all right. And PA projection. Again, remove the coronary sinus catheter because we don't need to see the decapolar catheter because this is enough. When you tilt slightly up and to the left, we see the ablation points at the bottom of left atrium, and now these lesions will be complemented with another lesions that will be placed to the very proximal and posterior or even posterior superior quadrant of coronary sinus. And I usually, just to avoid let's say coronary artery damage, I do the dragging here. So this is not, we usually limit the radio frequency to 25 and do some dragging here. So let's start, and I will slowly go out of the coronary sinus, and I do sort of meandering movement just to target point here. Target not only like pericardial aspect of the coronary sinus, but also the more, let's say, superior, adjacent to the botany, adjacent to the left atrium. And I am slowly approaching to this AV nodal sweet spot at the bottom of left atrium. And again, like to have some consistent ablation, we usually deliver 90 seconds of ablation by dragging. So now I'm pushing the catheter a little bit out because just to target the pericardial space, not to, because this is not like when we ablating atrial fibrillation, and we want to ablate more to be attached to the left atrial wall. This is simply opposite. Botany.
And also on the eyes, you see the catheter on the base of this pyramidal space.
Yeah, exactly.
I showed on eyes here what is the pyramidal space.
All right, so almost 90 seconds, perfect.
Again, intracardiac echo is useful for many things, and what you can do in the EP lab. Whatever you do, almost.
And we will recheck again. So I go for fluoro to check if the catheter position in right jugular is all right. It's almost all right. I am trying to go back to original site. It is there. And again, we are interested in AV nodal response only, so we do high frequency stimulation.
Can we have big screen with signals, please?
Big
screen with signals running.
Yeah.
Okay.
Bruca live. So we are pacing, and we may start with high frequency stimulation.
See?
Okay.
No.
Slight prolongation, but without block. Yeah.
There was small prolongation, but no single non-conducted atrial beat. But still, it means because the baseline response was relatively weak. We can't rely, and we should ablate more. And our empirical strategy is based, in all cases, includes also the third aspect, and this is inferior posterior right atrium. Predrag can show this on eyes. I start from the very bottom of fossa ovalis, from the aspect of right atrium, and this is the third base of this pyramidal space.
So first he was ablating here, then inside, and then from this side. So
exactly. This is like triangle around this pyramidal space. We may ablate, and again we may increase to 30 volts.
We call it triangle of Wichterle.
Let's ablate. And again, I prefer to have 90 seconds of radio frequency, and I do this by slow dragging towards the ostium of IVC. Tady ještě jeden.
We moved.
Yeah, I know. I'll go back.
Dane, so when you finish this and you do again testing, we may move to the other lab, and before you start to ablate for assay node, okay? When you do testing now, after testing we move to another lab because I think they are already done more or less.
No. All right, no problem. I will give more 10 or 20 more seconds here.
I think everybody is curious how the result will be now. So let's wait a few minutes and then move to the other lab.
Stop. It's enough. All right, so I am again checking the catheter position inside.
Is there any change in PQ interval? Can we see?
It's unlikely because it's.
So can we see signals now?
It's pretty normal.
Do you hear us?
Yeah, well, in a minute, Peter. In a minute, we are just testing the result. Why are you changing this? I did not say.
The correct position. Nepotřebujeme mapu, potřebujeme. Please show the Pruka live because we are ready for.
That's what I said already. I have to repeat again. Can we have a running screen on this in the lab where Dr. Wichterle is? Okay. Now, thank you.
All right. So we just started.
So pacing.
And there is still prolongation.
So what will you do?
All right. So this empirical lesion was not able to completely denervate of AV node. In fact, it was a significant effect. And I am absolutely sure that when we ablate the superior ganglia, it will disappear completely. So
okay.
You may go to.
So we go to the other labs. Now. Thank you. Thanks. Petr. Petr.
Hello.
Okay. Yeah,
so
you are
this is
obviously
you're interested what has happened, but let me first tease you a little bit. So just to review, we did 3 lesions with lesion index 800 using 40 watts, using this anatomical based approach. If I would just want to show you the first application in review screen maybe first, what we prepared for you. So this is ablation number 1, and that was kind of nearly immediately in effect in terms of heart rate increase. So this is prior the ablation, and after a few beats, I don't know, after a few seconds it was 90, and then we reached to 120, and we did additional 3 lesions. Then we checked for the Wenckebach point, if you remember, there was something about 520 milliseconds or 40 milliseconds. Now when we checked again the Wenckebach point, it was about, in the measurements in the milliseconds, 333, so 200 milliseconds kind of shorter. So tremendously from 111 beats per minute to 180 beats per minute. And then we positioned the catheter in the jugular vein to do the pacing. And we did it repeatedly. And this was first when we did it. Previously we had a 10 seconds pause during the jugular pacing on SA node and about 6 seconds pause on the AV node. And we did it repeatedly. There was no effect on the sinus node. Only with one position of the catheter we had 2 non-conducted beats on the AV node. So this was one pacing that there was at least not a maybe elimination of the vagal innervation to the AV node, but modification. But it was only once, and then we tried to repeat it because there's kind of variability exactly where you pace, and there was not really any beats that would fall out, what would be not conducted. So just show you this would be during pacing in the CS, 120 beats per minute, and there's no non-conducted beat, and we repeat it about two times more, and with different trying to search for, because that's also important to I believe to have a good. We recorded, stored the position on X-ray where we did the first pacing, which was the tremendous reaction. But it seems so because of these large lesions and the correct spot, I would say, there is a tremendous denervation of the sinus node, and maybe not complete, but nearly complete elimination on the AV node. Maybe you can comment on that?
Just importantly, I insisted on the lower part of this target line just to have an impact on the physiology of the AV node. We have learned that this is important to insist on this position. And then as I mentioned this morning, it's very important to be not beside the right spot, but to be on the right spot, and it's very reproducible with our ablation strategy, and to give from the first time enough amount of radio frequency energy. And then you can have a complete sinus node denervation with a unilateral approach and only 3 applications of radio frequency energy. But we are happy with the result.
Philippe, if you have patient who has predominantly functional AV block, would you still do just this procedure, or you go to the left atrium or modify this lower area which has more
if I have patient with
AV node?
If I have patient with AV block, I will not go to the left atrium in primary intention. I will approach the triangle of Wichterle from a right-sided approach.
Okay.
It's also possible by knowing the anatomy to be on the right spot from the right side. But with our experience, as I said this morning, for AV node modulation is too limited to make a strong statement. But for the AGP, I can really make a very strong statement, because we have in more than 100 of patients, we have always the good response since the first application. So I'm completely sure. For the AV node, I recognize we need more data, but as I showed this morning, probably if we learn more about the position of this structure, we could achieve the same from the right side. That's what I think. But it must be proven.
Do you ablate in coronary sinus, in proximal coronary sinus, or just from right atrium?
I try to avoid it. No, it's in the vicinity of the coronary sinus, but I try to avoid it, and I have the tendency to prolong the lesion toward the inferior caval vein, because in one patient we had a re-entrant tachycardia after a focal ablation in this area. But once more, I have to recognize that my experience of functional AV block is limited. We treated 5 to 6 patients, and for sinus node functional sinus node dysfunction and neuroindicated syncope, we treated, I don't know the exact number, but far above 100 patients. So this is not the same experience.
Okay. Any question?
But I think we still have to learn more and to find this a new target line for this IRGP.
Yeah, there is a question.
I think it's not by chance that we, yeah.
As regards
my conviction is that
Michele
we cannot hear the question.
As regards the V node,
yeah.
We should consider a couple of things. First, vasovagal syncope very rarely affect the V node alone. Maximum there is sinus bradycardia plus some blocked P wave. So this is a good target for vasovagal syncope. But if we have a syncope with heavy block, with constant PP cycle, this is unlikely to be a reflex syncope. So is another point. But again, going back to your previous question, the only way to know how much, when, how much to ablate on the right or left side of the node, we need to compare the result with the clinical result. We have no possibility. The only alternative is to implant loop recorder, see what happens.
Fully agree.
During the lab, we do not have a standard of reference.
Okay, thank you.
No, you're completely right. We have to avoid to be dogmatic, and we miss the link between the procedural endpoint and the clinical evolution. And I would like to modulate the physiology and not to destroy what the nature has foreseen. I don't want to destroy the little brain of the heart. I would like to find a minimal change able to predict a good outcome. I don't know if it's feasible, but at least we should try. That's my opinion.
Philippe,
just an opinion.
Piotr Kulakowski. So this lady has now 110, 115 sinus rate while resting. If you see this patient 1 month, let's say 1 or 2 months visit, and she will have the same heart rate and would not tolerate it, what would be your approach then?
No, but how to say? We all know that there is re-innervation after this kind of procedure, and that it takes time. So I explain it also to the patient, and of course, if for symptomatic reasons they have a too higher heart rate, we try to give beta blockers just for symptomatic reasons. But we really explain to the patient that in most of the time it will be transient, and we set it heart rate will be intermediate between the heart rate they had before the procedure and the heart rate they have at the outpatient clinic. I know that you explained me that sometimes you had a difficult situation with one of the patients regarding this, but this is really an exception. But like for any new therapy, we should follow this, of course. It's very important to learn more about this. I agree. But I try to save time, to explain to the patient, to wait what's full thinking, and then most of the time it doesn't remain a problem, at least in my experience. In this unilateral approach. Maybe if you are still even more aggressive, you will compromise the re-innervation, which could be positive, which could be a good thing. We don't want to denervate the heart. We want to modulate the physiology. So we know that you will have some kind of re-innervation. But if you, conceptually it's not proven, but if you destroy all the other GPs, like some people advise to do, from where the re-innervation come from? So I'm against this approach of a pan-ablation. I don't want a pan-ablation.
There's one more question.
But that's only an opinion. It's an opinion. This must be investigated.
Okay. No more question? No more comment? Do you have something to do more, or you've done?
No.
No. To say goodbye.
It's 3 lesions.
Oh, okay. Well, thank you very much for this demonstration. I think it's a different approach, as we could see. So we will see where is the truth. We will see in the future. Okay. Thanks a lot, guys.
Excuse me. Thank you.
Jo, tak zpátky. Dané, už jsme zpátky. Už jsme zpátky, jo?
Alright. We are waiting. We haven't done ablation for superior ganglia, just to show it in live case. So, prosím, teďko všechno pryč, pravou síň jenom. We will show one recording because we did right vagus stimulation in sinus. May I have Pruka review? It's Pruka review, yes. Yeah. And show electrograms as well. So we did right vagus stimulation in sinus. There was sinus plus minus 80 beats per minute at the beginning.
81.
And now you see the artifacts of high frequency stimulation. And there was immediate switch to junction, and to very long junction. Junction initially was less than 50 and go forward. And there was slow acceleration of junction, but no sinus for 20 seconds. So of course we can't assess the maximum sinus pause because it interferes with junction. But this interference is there because junction is already maybe not fully, but significantly denervated. And that's why the junction here with frequency of maybe 75 is faster than sinus. So definitely we have some sinus response, but we can't assess this numerically. But at least it drops from 80 to less than 75 for the period of at least 20 seconds. So this was response. And now you see when you go for Pruka Live, you see that we have persistent junction just now, 72. And again, this is the principle is same. Denervation of AV node and no denervation of sinus node. And we do this just now. And we start from the aspect of right atrium. This dark violet point is our sweet spot. It is almost the same, I would say the same site where the Philippe Debruyne is burning. Is very posterior aspect of the right atrium superior vena cava junction. And when you rotate to the slightly to the left, you see these like light blue points that annotating the roof of the right appendage. So we know that we are at the same level as a ridge between SVC and the right appendage. So this is true ostium of SVC. Maybe we went a little bit inside SVC, and that's why So it is a little bit higher than this ridge between SVC and the right appendage, because we are relatively close to the sinus node, that you can appreciate the position of sinus node by activation mapping. But you see, when you look at the color bar, there is activation time is 87 for sinus, and when we click, when we select some point nearby the catheter, it is, how much is it? 65. So we are 22 milliseconds from sinus, even if the anatomical distance doesn't look so high. At least electrically, we are 20 milliseconds from the center of, or from the endocardial breakthrough of the sinus node, and it should be safe to ablate here. We are also distant from the phrenic nerve. All these green tags are for phrenic capture, which was tested and annotated prior to myorelaxation, because during myorelaxation this may be less reliable, and the distance is, let's say, 1 centimeter. So this is our sweet spot, and we give the first RF delivery again 30 watts and 30 seconds. And you may see, maybe it should
maybe.
Yes, signals, because sinus may accelerate very early and again overwhelm this accelerated junction. Yeah, ablate. And it was ectopy, but I don't know. No, it's sinus already. Stop. I wasn't sure that there might be catheter dislodgement. I'm again stable. Yeah, please, Bern.
Yeah, nice acceleration now, actually.
Yeah.
110, almost.
I don't know why there is.
So you see in the similar spot
the
increase in heart rate very quickly.
Yeah.
Maybe we can.
I think it's stable. My feeling is catheter is stable. This sort of, I don't know, some Carto artifacts. Yeah, good.
Here is the catheter on the eyes, if you can see.
Yeah, it's nicely hooked there. And what we usually do is that I go away from the phrenic, and we give, sometimes I go slightly more lateral, but not too much. Let's ablate here. Shorter delivery, because we are approaching the phrenic. And then I will go more septal, just to have at least 3 deliveries each 30 seconds. Maybe 4. Oh. No, 3 will be enough. And we will go, we will create the contralateral lesion from the aspect of left atrium as well, just to, we will test after this, and we will see. Stop. And I got third lesion here, a little bit more lateral, please show me. Yeah, blade here. So this is our
additional acceleration.
Yeah. I know it's like, it looks like too much, but it will go down later on. We have a formula how to guess the 3 months sinus rhythm rate, which is based on baseline sinus and also on atropine acceleration. And I calculated this for this lady, and the estimate of 3 months sinus rhythm is 87. It's not so bad. Even if now you see it goes down, because there might be part of the acceleration might be like sort of heating of sinus node. This is not, this might not be the denervating effect, but direct damage, or not damage, but because it's difficult to damage sinus node, of course. All right, so I think we can test it just now. I will go again back out of the, not to avoid touching the atrium and creating ectopics. I will check the catheter position inside. Yeah, I think catheter is perfect. And we retest high frequency stimulation, right vagus during the sinus. And then we will do this during atrial pacing, if there is disappearance of this prolongation of AV. Yeah. It is not innervated. Again, you see junction. So this is not enough for sinus.
So despite this sinus node acceleration, we don't have a complete loss of responsiveness of the sinus node. Yeah.
Exactly. So there was sinus, and junction.
Yeah.
Again, we don't know what is the true pause, because it's like hidden by this junctional rhythm, but definitely sinus node is not innervated just now, and we will go for left atrium to, or what we can do. We can do high frequency stimulation. I lost the site. I'm back there, and let's start pacing, atrial pacing. And can you see Pruk alive, and we will check if there is still this tiny prolongation of AV during high frequency stimulation. You see? Yeah, there is some. There is still some. Yeah. All right. So we have to go. We have to go to the left atrium. Perfect. Takže bych potřeboval jenom levou síň dírou vpřed. Neplus normálně.
You're in. Okay.
And I go to contralateral side. And this red point is like contralateral point against this right-sided, or almost a little bit out maybe.
Yeah, maybe you have to
right-sided sweet spot. Yeah, but it's all right. We want to blade against this, not single point, but against the line.
And again on ice, you see that we are on the true PV ostium of the right superior pulmonary vein.
Yeah, I think we may blade here. And according to catheter stability, we give 2 or 3 lesions here. All right. I will go slightly out, like here. Blade.
See again, you can use intracardiac echo to place catheter in front of the pulmonary vein to avoid ablating inside the pulmonary vein. Also for AFib ablation, obviously.
Počkej, neber to, já chci být venku, jo. Teď. I would give maybe one more if it is stable. Let's wait until the catheter is really stable. It's difficult here, blade. All right, stop. It's enough. Maybe I will give one more lesion a little bit behind this. This is not ostium. In fact, it is white antrum. All these white tags. Oh, not maybe.
It
This is
is
osteo. All right.
osteo, yeah.
So maybe we will retest just now. I will go somewhere. Avoid irritation again here. And
so these 3 ablations should transect the dominant input from the.
I think so.
We believe that.
All right. So I'm checking the jugular catheter position. I think this is perfectly at the same side. And we start again with stimulation in sinus, and subsequently with yeah.
Oh.
Yeah,
nothing,
I think
nothing happened here.
It's done. So sinus is denervated at least just now. Is there is no.
We have one PAC here, and that's the reason of this pause. But otherwise, it's
so it was like
complete loss of responsiveness.
Yeah.
Nice.
It is good. And we will retest during atrial pacing to see again, check for this tiny prolongation, if there is or if there is not. And it's
good.
Yes, still there.
Oh.
All right. So there are 2 possibilities. Either if we want to get rid of this tiny response, we have to either extend something, either extend this superior lesion or inferior lesion, or to ablate superior left ganglionic plexus. Let's try to do this. I'll go back. I am in left atrium.
You want to show the left-sided veins, right?
Yeah.
Okay. Okay.
No,
we are in the vein, actually. No.
Já myslím, že když tak tam ještě tady to, because these talks are not accurate, because there was no idea that we will be ablating here. This is the last resort. If it doesn't work at paraseptal positions, usually ablation at this side, možná vyhoď tam nějaký ty bílý, jo. Teď jsem
No, we are out of this.
Teď jsem vypadl, už jsem tam byl. Ještě jednou zpátky. To je pryč, to vyhoď pryč, a tam do zpátky.
No.
Ukaž mě tam, jestli tam jsem. Teď tam jsem. Tady vlastně vem bod, a tak on asi byl dobře.
Sedí,
asi byl dobře. Dej mě right lateral a tilt down. All right. Blade here.
30 watts.
This is important ganglion. Usually there is no need to ablate. I think we ablate this ganglion in 5% of patients.
Done. It's Alan. Again, one question. Can you comment on... Can I have a question? Can you comment on energy setting? Because we have seen Philippe ablating with ablation index reaching 800, which is tremendously high, compared to your 30 watts, 30 seconds ablation, which gives you an ablation index approximately of, let's say, 400, if you have a really good contact.
Yeah,
so can you comment? Can you comment on this? Because obviously the approaches are different. You need a uni-chamber, bi-chamber approach. The energy setting is different. The vagal testing is different. So how can we definitely plead for a randomized trial if we are not able to agree on the technique and ablation side? So Michel will be happy forever because there will be no randomized trial at all. Finally.
It was discussed at the end of the lecture session this morning. So it is difficult because each operator has some preferred way of ablating, and probably it's difficult to switch for another like non-validated strategy at particular institution. It's difficult, yeah. And in terms of Philippe ablation, probably he compensates the unilateral approach by large lesion. It's logical. We ablate less, but from both sides, and so it's like sandwich ablation when you ablate LVOT difficult ectopy. So we ablate from both sides, like you have seen anterior antrum of right superior vein and very posterior in SVC, and this is the sweet spot. All this region. So you may ablate less from both sides or heavily from one side. I don't know what is. Nobody knows what is better. We may test it later on in some technical study. Let's randomize for this bilateral approach for sinus nodal denervation and test it using acutely, intraprocedurally using extracardiac vagus nerve stimulation. What is more effective? But of course, we should use smart touch catheter for such a study. We normally don't use. I rely on my experience. Maybe it's not optimum. But let's ablate here. So we should have give some couple more lesions. I'm nicely hooked in the left superior vein, and now I'm more superior, and I will go, let's say, closer to the Marshall tract, more anterior, maybe AP and tilt down. Yeah, more tilt. Yeah, dej mě pryč tu hlavičku. Stop. To vypadlo. Ups. Je to tam dobře? Asi jo, počkejte. Trošku to nazvedně is deep. I'm approaching the...
Back,
yeah, no, it's almost there.
Now it's on
blade here.
If I may comment,
and
I think if you do not agree on some same protocol and do multi-center study, this will be all the time the same problem, because you can claim that your technique is better, the other will claim that his technique is better. So until you really reach a certain, let's say, compromise and do the study, and I believe that we have enough centers now, friendly centers, let's say, or somehow connected mentally, that we could do such a trial. It's just a matter of decision, because without that, I see that we get no major progress. I mean, because if it's not accepted in guidelines, people will not send you that much patients. You know, it will be always struggle, and so it would be much better to have solid data. Am I right? Piotr. You have to jump. Microphone.
Stop.
Unless you are happy with 2B class. Why not? 2B class is, you may consider this. You don't have to do this. This will be in the table in the guidelines, and 2B class should be obtainable now with this data, but only 2B, not more. I have a question to Alan. To Dan. Dan, can you tell us now what is your policy in this patient afterwards? I mean, how you switch off or put down the pacing, and when you will take out this pacing system if there are no symptoms in this lady. What is your normal policy?
Normal policy is first there is sort of follow-up with low basic rate. Subsequently, then we switch to like sub-threshold output to see if there is no symptoms when the pacemaker is completely switched off. And usually the follow-up period is at least 1 year. And because the implant was, I think it was
recently,
so
6 months ago,
extraction
maybe.
Could be like no problem, but I would prefer at least 1 year follow-up since the procedure before we go for explant.
So it is the same as in our center, although also I would like to take into account the frequency of syncopal episodes before, because sometimes there are people who have 1 syncope per year, so maybe then follow-up should be slightly longer, but in these patients who have 4 or 5 syncopal episodes per year, I think half a year or 1 year should be absolutely enough, and extraction is easy then.
Yeah.
Exactly.
I will go slightly to the roof. A blade here. No, možná ten klidně jeden vyhoď, nebo dej floating, nebo něco s ním udělej. Dej ho floating, tam to vyhoď. Stop. I think it should be enough.
We can test it.
Yeah,
now.
we will test. I do this because we have a weak endpoint. We have no left vagus stimulation for AV node. So that's why I want to achieve, hopefully, complete non-responsiveness for right vagus. Because if we pace left vagus, it may be different. But there is no way. There is non-accessible internal jugular vein. No, yeah, při pacingu. Ano.
Okay.
No. All right. So maybe one more ablation at the bottom of left atrium, please, PA, and if it is not effective, I would leave it like this, with this like tiny response. Sedím tam dobře, nebo?
May I ask you, who is doing ablation of this cardioneuroablation in the audience?
Jsem tam, jo, teď jsem naproskočil teprve.
Okay, so yeah, three centers in Czech. You are the same with you're different. And how many centers in Poland? Sebastian also is doing?
Sebastian is a multi-center person in many centers. We are doing, and I think that some other centers also, but I think that there are many patients sent to us, so I think that we are the main center in Poland now.
Actually, in the US, they are, despite they have no, certification, FDA clearance for the stimulator, there are some centers providing this cardioneuroablation, like off-label procedure.
Yeah, but they are five years behind Europe approximately. If you read very nice case reports and heart rate case reports from the past half a year from United States, you will see very nice case reports how not to perform cardioneuroablation without atropine, without extracardiac vagal stimulation. This is very educative, but I think that Europe is much ahead of US in this area.
Who believes
in
the patient who has
the case is really problematic because we start burning at the
guys,
bottom of
we
the
don't
left
believe.
atrium
We know.
No,
it's not belief.
It's more like
put them all.
Politically correct expression. Who believes?
Okay.
Jdeme AP, já půjdu se před ty žíly. Nevysunulo se nám CS už.
I have some comment to Michal. Actually, you mentioned that maybe less invasive, maybe Petr as well. Do you think that leadless pacemakers can affect this perspective of cardioneuroablation?
Again, we need a trial comparison, leadless versus dual champ. But in theory, I am afraid to implant a leadless ventricular-only pacemaker because we need the atrial pacing. By ventricular leadless pacing probably is a promise.
for this infrequent, infrequent syncope, not like frequent syncope.
It is not a matter of frequent or infrequent. It's a matter that to avoid the vasodepression. Now, we know since 50 years that the pacemaker effect of a VI pacemaker. I remember that in the 80s, we stopped the implanting in patient sinus rhythm with VI pacemaker due to the pacemaker effect. So pacemaker effect remain also for 40 years later. So we have absolutely to avoid pacemaker effect.
But you will get dual chamber leadless.
With a dual chamber leadless, I am in favor. But dual chamber leadless, we still need to wait 1 or 2 years the results.
But, actually, paradigm is if this procedure is preferential. I think for me it's preferential than pacing. For young, you said for young people, for young patient, it's much more effective, right?
I believe, because I see for many years now the effect, I believe that it works. And the quality of life is much better. But there is one aspect which we also have to take into consideration, which was brought by Dr. Debruyne, that you can modify significantly the vagal, let's say, innervation, and this may have some consequences later during the life of the patient. So we don't know. I mean, we know that if you have higher heart rate variability, you have probably worse prognosis in general. So we don't know what it does in after 10 years, 15 years. So we have to be always a little bit cautious. So this is, you know, I'm always excited, but sometimes you have to consider also this, because the same was with this radiotherapy, you know, a lot of excitement. Then you see mitral valve replacement, fistula. You know, this is not completely harmless. So we have to consider always some possible negative consequences which may come after years, not after the procedure immediately.
This is the reason why I prefer a partial approach. I am not afraid of reinnervation. We can easily perform a redo-ablation if needed. There is a spontaneous decrease of syncope recurrence while the patient becomes older. I am afraid to have no valgus effect when I am 60 or 80, 70 years old. So I am not afraid of reinnervation.
Any other opinion, Piotr?
I think I covered this in my talk exactly.
I'm sorry I could not listen, but I will listen it later because we have everything
you could see
recorded.
our old pictures from 1998. Yeah, I simply said the same, that slight reinnervation maybe not as bad as some people think, that it could be 100% vagal inhibition, and that's all.
There is nothing white and black, something in between.
Sometimes it is, but usually in life not. I agree.
But as Lenin said, if it's in the interest of working people or working class, it could be one day red, and could be one day black and one day white. You know, so this is the other approach. Right? You can modify based on what is in the interest of working class.
Absolutely. And looking at this nodal rhythm, which is all the time, it looks that this lady has mixture, has some functional but also some intrinsic problem. So we shall see afterwards.
It will be interesting follow-up next year. We will give you a 1-year follow-up during the meeting again. Any other questions, comments? So, Dane?
Yes?
What is the next? What is your now decision?
I don't know, because it is more and more difficult, because we try to eliminate this tiny AV nodal response, and we ablate it again at the bottom of the left atrium, and we cause the acceleration of sinus. And now acceleration of junction. Now we have junction of about 70 beat per minute, and we have no sinus. And we reblated again this superior paraseptal ganglionic plexus, and we are not able to accelerate sinus over this junctional rhythm. This may be because of anesthesia, but we are in sort of like deadlock now.
Maybe it's time to
I
finish.
don't know what to do next. Yeah, probably, because when the patient will be awakened, she will return definitely to the sinus. But now we have no possibility how to test. Now we are just checking AVN, ERP, and Wenckebach point if there is some change. But these parameters were not so bad at the beginning, and as I told in my lecture, it is not a reliable endpoint. But now there is a persistent. What we may do is to give isoprel to see, at least to see sinus for a while. Dejme isoprel.
Můžeme isoprel naředit, prosím.
Maybe I would add one comment.
Can you enable this microphone, please?
Maybe now,
Or
yes.
We can test it with
Dan,
Tady ten similarity si děláme, nebo co děláme teďko?
I think that Dan thinks the same because we have similar. Dan, I think that you just told, but I think it will be important for the audience that when doing under general anesthesia and muscle relaxation, all these measurements with sinus rate and Wenckebach are not so important.
Sorry. There is return of sinus, all right, continue.
Yeah, but when you do this, let's say, simplified cardioneuroablation, then you can more rely on this electrophysiological measurements. But so I agree with you that this is very likely that tomorrow she will have nice sinus rhythm and no nodal rhythms. And my very brief question is, do you consider sometimes that you did something to one of the small coronary arteries while burning, and when you have no sinus node, for example, for a while, or is it not important?
I think the absent sinus rhythm is not the issue, because this is because of active junctional rhythm, because the maybe sort of it depends on balance between activity of sinus and AV nodes, and on the magnitude of the denervation. Hopefully they are denervated quite almost to 100%, but it depends also on balance between this like intrinsic rhythm. As regards your question was also to why we did drugging in coronary sinus and decrease the radio frequency output, or I don't know if this was the question.
About coronary arteries.
Yeah, we had one complication, one occlusion of distal circumflex, which was treated with angioplasty without stenting, and no like long-term disability or no LV dysfunction. Like it was MI, but no long-term problems. So since then, and it was after delivery, I think 30 watts, maybe almost 30 seconds at single site at the proximal coronary sinus. So since then we decreased the output, and I do the drugging all the time just to avoid stay at the same site for a prolonged period of the time. I would like to do some final testing, because now we have sinus and we may do this. So I will check the... Prosím, srovnejte jí trošičku hlavu, má ji na křivo, jo? Tak, catheter is in place, and we do again. If you see Pruka live, can you switch to Pruka live? Yeah, all right. And so first in sinus, and subsequently in atrial pacing.
No sinus pulse.
So sinus is all right. No slowing, or no visible slowing. No. And yeah, pacing. We will see, because we add some lesions. Yeah. You may measure the longest AV during the train. Maybe it is a little bit less visible than before.
Mm-hmm.
If we measure AV just prior to the train, and let's say here, and measure from stimulus to the peak of QRS, just to be accurate. Yeah. All right. 205 or 03.
So by 50 milliseconds it's prolonged.
No.
We have 205 and now we have a 255. Right? So 50 milliseconds.
All right, 50
prolongation.
milliseconds. All right. So, and my choice is not to extend ablation, because we did all the empirical sides, and hopefully it will be enough clinically. Yes. So probably that's all. If you have some more questions to any aspect of the ablation.
We have a question in the auditorium, please. Yes.
Hi, Dan. Does it work? Yeah. Hi, Dan. Michał Farkowski. Michał Farkowski speaking. Great case. Could you please repeat, how do you choose those sweet spots? Is it on some anatomical landmarks, on signals, by experience? How do you choose those sweet spots?
Yeah. Yeah, we may repeat this again. Please remove the coronary sinus. I am.
You're in the
no,
in the right one.
All right. So I will go back to the left atrium. I need. Potřebuji se dostat doleva. I will reproduce all the manipulation. So AV nodal sweet spot in left atrium is PA, please. What I always talk is my posterolateral mitral annulus. This is the most bottom blue point, and the posterior ostium of right inferior vein.
Yeah, the lowest point, white point. Yeah.
And so it is, the sweet spot is in the middle between the blue point and this ostium of right inferior vein. So and of course, if you have possibility to use the eyes, it's even better, because now I'm approaching. I have sort of loop back-end configuration of the catheter, and this side that is stacked by these blue-violet points is around this pyramidal space. From the aspect of left atrium, there is no need to go more to the septum like this. Now I'm, if you can display, now the catheter tip is sitting on the like this thin septum. There are no ganglia. You have to approach to this pyramidal space. So the middle way, this is very posterior, very bottom, middle way between posterolateral mitral annulus and posterior ostium of right inferior vein, close to the bottom part of the fossa ovalis, and of course if around, and this is the only left atrial aspect. The same can be done if you include the coronary sinus, and this is the center, and all subsequent lesions are centered around this left atrium sweet spot, and you see how close is it, all these coronary sinus ablation sites are very close to this dark violet sweet spot. And finally, when we add the right atrium, this is the last let's say side of this pyramid. So this is our strategy for AV node, and we may repeat again how we select the sweet spot for ablation of right anterior ganglionic plexus. In fact, this nomenclature of right anterior is very misleading, because in fact it is not right anterior. It is anterior to the left atrium. Anterior to the left atrium is anterior aspect of antrum of right superior vein. But in terms of right atrium, it is very posterior. So it is not anterior, not posterior. Sometimes it is called superior ganglionic plexus. And I suggest for this plexus the term superior paraseptal ganglionic plexus, because it is at the septum. It is not right, it is not left.
Yeah.
It is not anterior, it is not posterior. Yeah. It depends how you look at it. And in this position paper, which will be published soon, which was written by a writing group led by Michel Brignole, I suggested this term superior paraseptal ganglionic plexus, and I hope that it will be used in the future, because it was my idea.
Yeah, for the purpose of cardioneuroablation, it's more appropriate than.
All right, so please go away with remove the left atrium, and I will just briefly repeat how to find this. First, you have nice map of SVC. Now we are looking from the PA projection. You should touch to the left. You should touch to the right, just to know that you have full volume of the vein. And then you go. This sweet spot is in the middle, in pure PA projection. Yeah, we are in the middle, not septal, not lateral. And in terms of vertical direction, we are at the level of the ridge between SVC and right atrium. So if you rotate
appendage, right atrium.
Right appendage. If you rotate to the right, I will engage right appendage again. Of course, if you have eyes, you may check it directly, but you may find it also by catheter manipulation, because you see now I'm sitting. Drug will try to display the catheter. Now I am inside right appendage. All these light blue tags floating indicates the roof of the right appendage. And if you are experienced, you don't need eyes. Of course, if you have eyes, it's even better. And now I am dragging along the roof of the right appendage towards the ridge between right appendage, and I'm approaching the ridge. Now I'm exactly at the ridge and bending slightly towards middle of the right atrium. It out of blue, it jumps. It behaves not normally here. I don't know. Oh, it was not good example for teaching. I go there again. I am at the roof.
Now you see the catheter in the right atrial appendage.
Yeah.
You see the right atrial electrode insertion.
I go back until it jump until maybe it looks like there is change in anatomy. Trošku doprava mě to. Yeah. But I think this more proximal light blue point is just now I am in the SVC. I am dragging back in SVC, and it jumps to appendage just now. Yeah, this is jump. So it jumps around this more proximal light blue point here. Now I am exactly at this ridge, and this is the level. This is the like vertical landmark for identification of this right atrial sweet spot. We went a little bit more inside as we see because it is not all absolutely the same in all patients. It is like average successful position, but you should adjust to first to sinus node position and to phrenic because it's important not to cause any damage. All right, so if there are there any
any other questions, guys? I think, well, Dan, so to summarize the case, we are a little bit ahead of schedule. We're still, some time for education. Actually, you know what? I have an idea. Can you stress the, RF, right? So we have cardioneuroablation. We do get RF, okay? How about the PFA? Can you stress
PFA,
our study, the BTF study, what we are doing?
At least with protocols that are used for myocardial damage, for example, for PV isolation, it is insufficient to create permanent or even temporary. There is some temporary effect on nerves, but the effect is really temporary. It disappears. It depends patient from patient. In a couple of minutes, it weakens, and I guess that in 1, 2, 3 days it disappears completely. Yeah. So PFA in configuration that we use for PV isolation is not useful to ablate. There is no change in sinus rate. There is no change in other EP. Almost no change in other EP indices. So if the PF energy can be, if this is used for neural ablation, it should be changed. And you did a study with Ivor Skalski, some surgical study at Homolk Hospital.
Oh, you are open this black box as well. Just before publication, I am not able to speak about. Actually, the project is roughly. The project is interesting because it's a PFA, modified PFA, applied from epicardium. So we just try to understand if we can lessen the atrial fibrillation, like post-surgical in post-surgical patients. So post-surgery patients. So we can improve or change the effective refractory period. So actually, I am not supposed to get any results, but to speak about. But actually, it might be some applicable method how to apply PFA to surprisingly not damage myocardium, but to affect the ganglionic plexi. So it's still a lot of questions not answered.
Some preliminary results were reported at ERA meeting last year. It was poster or abstract presentation, and there was significant shortening of atrial refractory period after this PFA epicardial surgical ablation.
But yes,
but this is
okay.
Only
significant. Perfect. Not too much.
Yeah.
Not significant. Okay, fine. Okay, we have
another
question.
Oh, like
another
20 milliseconds.
Gentlemen, do you think that the lack of effect on ganglionated plexi by PFA will affect effectiveness of AFib ablation? Do you think it will affect effectiveness?
Actually, it's a different
Hopefully
aspect.
not, because...
sorry. Go ahead, Dan.
Hopefully not, because even if there is some effect, it will be like counteracted by more persistent and more durable PV isolation after PFA. Hopefully, yeah. But nobody knows, and if this should be investigated, the design of such study should be a PFA isolation in all patients and additional RF ablation for ganglionic for denervation by radio frequency in half of them randomized study. Otherwise, we will have not answer. Yeah.
And Peter, what do you think? Peter Neugil, what do you think?
Me?
Yeah. I ask both of you.
You know what? Actually, I would love to get back. Speaking about PFA, because actually it could be a really reasonable way how to apply for surgeons something with PFA. Because remember, the first ever PFA was applied epicardially, clinically, 2017. And actually, then the project was just transferred to transcatheter endocardium. Okay, so it's just space for maybe Boston or somebody else to get a PFA for the box lesion during the surgery, plus maybe affecting the ganglion plexi as well as this company named Atrion, this is what we are speaking, and then mentioned this company publication. So I think it will be beneficial effect, right? Okay, for that.
Can I add something? I think that it may affect efficacy, answering your question, in some patients, because we are doing PVI to all patients, and there are different subsets of patients. So if you encounter a patient with so-called vagally mediated AF, young age, athlete, maybe there will be not so good results with PFA, because this denervation, I believe, may take a role. But in other patients, probably, as you said, there will be no difference.
Yeah. Okay. Okay, guys. So then, any other comment or what are some progression? So you stop. You are finished, right? As I understand, you get a very nice education of the movement of the catheter. Perfect. Okay. So that point, I think we can close the sessions. So thanks for Peter and Dan and Philip for all this, or Predrag, okay, these nice cases. And guys, we have a break now, a coffee break till noon, right? So till 12. Feel free to get a coffee, okay? And thank you.
Tak ještě poslední session, last session of this meeting, which is sort of pell-mell of different things, but maybe outlook into the future. And I'm happy also to announce that Sabine Ernst, who works now in London, will have a lecture about how to approach ablation of AF using magnetic navigation, and she prepared a pre-recorded case for us. She does ablation now through the radial arteries, so it might be interesting, especially for people who do have stereotaxis. And then we have a talk by Peter Peichl and by Vivek Reddy. So that's for the end of this meeting. So in half a minute we can start this talk by Sabine Ernst from London. It's 12 o'clock. Yep, we can go.
Dear colleagues, I hope you can see me and hear me well. This is the recording of my case in the box for the ICAM meeting, the 25th edition at Prague. I'm going to start sharing my screen. Thank you very much for the opportunity to present at the 25th edition of the ICAM Prague workshop. I'm really, really honored. And I'm very sorry that I will not be with you in person. It's just a matter of the travel arrangement and my impeding upcoming maternity leave that I can't be with you. So I hope you forgive me for this, and I hope to be with you latest next year again. I have very fond memories of being in Prague, doing live cases with Joseph and the team and Peter. And yeah, thanks for having me. Here you see my disclosures, and I'm going to try to tell you something that I've been interested in for actually a number of years now. And you know that I have a big hobby, magnetic navigation or telerobotic navigation. And for all the years that we're now doing this, we've always used the traditional access routes in most patients. And we have basically tried to mimic what we do with our hands and use the magnetic system for it. And we have kind of ignored a bit the advantage of the system that you can steer only the tip, but it doesn't really matter what the proximal parts of the catheter do. And the only place where we do this better is when it comes to congenital heart disease. But let me just state in the beginning that, actually it should be now 2023 here, that this system can ablate all kinds of arrhythmias, any atrial tachycardia, any supraventricular tachycardia, any VT, any VF, epicardial or endocardial, it really doesn't matter. It's available, has been shown equivalent in multi-center trials for all of these arrhythmias. And of course, radiation exposure is low. You can allow zero fluoro procedures with that. And of course, the operator sits outside. I don't need to tell you all the details. The only real occlusion for magnetic navigations are cochlear implants in my experience. Now, having said that, of course, we use the system where the system has its biggest benefits. And I see that in patients with congenital heart disease. So this is a very old paper I published more than 10 years ago with the initial experience here at the Brompton when I joined, and showing that by using a retrograde approach across the aortic valve and then the systemic ventricle in most patients, we're easy to ablate all kinds of atrial arrhythmias without being much limited I've never done a transbuffal or transhepatic puncture here in the last 15 years. And as the catheter is so versatile, you can loop it several times around here. This is, for example, a TCPC patients. We have been very happy to do retrograde procedures in congenital heart disease. It has been very well. The most times that we do this, and you see here an example, is that we merge with 3D DICOM images from either MRI or CT scans. This is another lateral tunnel patient here. You can see that we easily can track the ablation catheter. This is on the Cato system, merge with the existing scan, and then basically move 3D in this patient's complex heart. You see here someone with a common atrium and a single ventricle here. Very interesting ventricular configuration. So we would go retrograde across the aortic valve, through the VSD, across an AV valve, through an ASD, and then map the entire native atrium. So that's something that we do quite frequently, about 70 to 80 procedures a year at the Brompton. And that's where the strength of the system has been. Now, in some patients, a conventional approach, even if it would be a normal heart, would be impossible. And this is patients that are born, for example, with an interrupted IVC. You see here on the left-hand side such an example. Again, a 3D reconstruction. You can beautifully see the azygous continuation that comes up, bypasses the heart, and then enters the SVC, kind of in a hockey stick-like approach. Now, doing a transeptal via the azygous vein is essentially impossible. So if this patient would present with atrial fibrillation, the only alternative route to a retrograde approach would be a transjugular transeptal puncture. Now, equally, if you have blocked femoral veins, this is a young patient here on the right-hand side as an example. Again, a superior approach for transeptal punctures would be feasible, but are technically quite challenging. This is, to my knowledge, the largest series, again, published from my group 2 years ago, with 6 procedures in some of the congenital patients and some patients with blocked femoral veins. It's quite tricky. I'll show you a picture later on in the case discussion that we have in the case in the box to show a little bit more details about this. But essentially, it's tricky, it's long, you have a lot of radiation exposure in this. It might not be successful because the septum is tilting away from the actual puncture site. Now, why is that so exciting? Because that led us to think about, can we use the magnetic system in any other way? As I told you, you're steering the floppy tip of this catheter and you're changing the direction of the tip. So does it actually matter where you're coming from? And the answer is no. And the experience of the COVID pandemic and being seconded to ITU made me consider all kinds of access routes to the vascular system again, including learning from the so-called PIC line team, how to put lines in the arms, for example, just to overcome access limitations that we had in this chronic COVID patients. So we came up with the ARM approach. ARM stands for Alternative Access for Remote Magnetic Navigation, and basically means puncturing any other vessels beyond the jugular or subclavian and come from further apart. So it mimics a little bit, and it's not fully yet a radial approach, but it mimics and it is leading towards doing a procedure from a radial approach. And the beauty of that is, again, the magnetic system allows you to do so. Now, how large are the vessels, for example, of the arms? They are actually sufficiently large in most people. So this is a subset of, I think, 63 volunteers, not patients, but volunteers, essentially all the cath lab people at the Brompton. We looked at the vessel diameters for both the veins and the brachial artery. And you can see here in those graphs is that essentially in all of those colleagues, we had at least one vessel that would be large enough to house an 8 French catheter, which is the limit, of course, of the ablation catheter. Smaller vessels, typically that's the basilic vein, and smaller vessels can be accessed as well for the brachial or the cephalic vein. So for smaller diagnostic catheters, you can easily do that. So you have a choice of vessels. And you see here just an example of the brachial artery with the 2 brachial veins here, right and left of this left arm. So The technique on how to do this is an ultrasound-guided technique. As nowadays every central line is punctured with ultrasound, that's very easy. The same technique is the ultrasound-guided Seldinger technique. So you see the vessel, you puncture with a small needle set, ideally with a radio-opaque echogenic needle tip, and then you aspirate, same way, Seldinger essentially. What you see on the ultrasound is that you see the echogenic tip. You can see it, you can walk it down to the vessel, you see it in the vessel, you aspirate, of course, and of course you can visualize all the other tissues here, the artery again, and the second brachial vein. So technically that is very simple and straightforward. It doesn't really differ from the PICC line established work process. Here you can see the long axis view and in-plane technique. I find that slightly more difficult, but the nice thing is here you can see the bevel of the needle, and then you can see once you've advanced the wire, you can make sure that the wire is nicely in the vessel. And of course you can follow the wire up as well if you like. So that is giving you the axis side, and this is an example from a patient I'm going to show you a bit more details for. We had a venous axis here and then had to, because of a left lateral pathway, an arterial 8 French sheath here, and a young lad. You see here the cardio drive that is necessary for the magnetic system, so you can use the mechanical drive for the forward-backward movement. The magnetic system only, or the magnetic field only, turns the catheter, the direction of the catheter, but not the forward-backward. That's the mechanical one. But you can easily fix that to the side of the arm and then align the arm when the magnet's coming in to navigate position. So very, very straightforward. Here's the example of that case, left lateral pathway, as I told you. 2 catheters, a diagnostic catheter in the right ventricle with some proximal electrodes here to capture the atrium. The magnetic catheter, you can see here with the CAR2 icon, of course this is on CAR2 RMT, has mapped the aorta, has passed the aortic valve, just entered the left ventricle, and now is mapping along the mitral annulus. You could easily pass the mitral valve, but you can map from either ventricular or the atrial insertion of the accessory pathway. We did so and ablated successfully for this young man who had blocked femoral veins. And you see the fluoroscopy time in total less than a minute, procedure duration. One of the first cases that we did, 120 in total, with a ablation time of a little bit more than 2 minutes. Now, can we do more than this? Yes. First of all, let me show you how the arms look afterwards. This is 10 days of the same patient after the procedure, so you can hardly see this is the puncture site. And the nice things is not only was it possible to do that without the risk of pneumothorax, so there was no need for chest x-ray afterwards. There's no need for bed rest either. For simple procedures, it could easily be a day case. We admitted this young patient overnight, but nevertheless, it could have been done as a day case. Cost effectiveness, if you think it through, we need less catheters. You can do most of the arrhythmia treatments that we're doing with 2 catheters probably, especially if you have the spacing and the electrode configurations of your diagnostic catheter in a clever way. And actually some of the patients expect that from us. They're asking, how do you actually do the case when you consent them for ablations? And they ask if you can do it from the arm. And so far we had always said, would love to, but we can't. But now we've established that we can. Now let me show you the experience so far. It's not massive, of course, but it's a experience that is quite diverse. We've done some SVTs, we've done some left-sided pathways, as I showed you, a large cohort of PVCs, some atrial tachycardia and congenital heart disease, some pulmonary artery denervation, some atrial flutter, and then a cohort of atrial fibrillation and congenital heart disease. And that has been actually very promising. Now let me remind you before I come to the rest, and I'm going to show you a detailed case for the AF ablation in the case in the box. I just remind you to say, when did transradial approach for coronary intervention started? It actually is a long time ago. And initially it was a niche. It was just done for coronary angiograms in 1989, and then the first reports of PCI were added, and it just took a time for this to take off. And the Nowadays, I would guess that about 90% or more of all coronary interventions are done from a radial approach. And of course, there was a lot of technical advancements here, slender sheath, different wires, different guides. Everything is now geared towards this. And I predict the same, and I hope to predict the same for the EP procedures from the arm. Now, what's the benefit? Besides the fact that there is no bed rest and you might have a quicker turnaround, but you see that the success rates are similar, the risk is lower, especially for access site complications and major bleeding. And this is from chronic total occlusion interventions. So that's a large meta-analysis. So I think overall, if we think it through, there's a good chance that this could be successfully applied to electrophysiology as well. And I see no real reason why it shouldn't. Now let me conclude and say we can already ablate everything if we just mimic the manual approach with magnetic navigation. There's a nice impact on radiation exposure, obviously for the operator who sits outside. People like me that are pregnant have much less radiation exposure. That's actually very nice as well, of course. The ablation itself is as good as manual. We hope to apply things like pulse field ablation, of course, as well in the magnetic world. But the real fact that you steer the tip of the catheter is pretty cool. And now we can think about alternative access. And I think, I hope that we can establish the ARM EP first hashtag very soon. So thanks a lot for your attention.
We will follow with a pre-recorded case by Sabine.
Dear colleagues, I hope you can see me and hear me well. This is the recording of my case in the box for the ICAM meeting, the 25th edition at Prague. I'm going to start sharing my screen in a moment, and you will see my presentation, I hope. Yes, here we are. I'm going to show you a case of a procedure that we performed, actually two procedures in a patient that we performed here at the Royal Brompton Hospital. And you will see that we're struggling quite a lot with this patient. This is a 53-year-old patient with symptomatic paroxysmal atrial fibrillation with breakthrough episodes of AF and taking quite a lot of flecainide. She has left atrial isomerism, dextrocardia with a situs inversus, polysplenia, bilateral supracaval veins with the right-sided SVC draining into the coronary sinus, left-sided draining into the systemic venous atrium, which is on the left side, an interrupted IVC with a azygous continuation, and severe aortic kinking. Here's a 3D reconstruction of a CT scan of the same patient, and you'll see, put here AP inferior, and then LA1 ARIO views here for your information. And you see that the heart is pointing towards the right. The aorta is anterior, central, you could say. So situs inversus, the right atrium is on the left-hand side. You see that there is an azygous continuation, so interrupted IVC, and the venous blood from the legs come up, turn around, and then enter the the left-sided SVC right here, and then goes into the right atrium. So all venous access from femoral would be through here. Access from superior would be from here via that SVC. And of course, pulmonary veins, you see that here a little bit in the inferior view, squeezed together a bit and elongated. So kind of a funny rotation as well. And please also note that this patient has quite a substantive kinking in her aorta. So instead of having a normal aortic arch, there is a very tough kink here, which prevented us from contemplating a retrograde approach much earlier. So let me show you the first procedure that I've performed in 2020 for this patient. And she was referred from another congenital center here in London. And they had tried to do a cryoballoon ablation with a superior approach, which was very, very difficult. And I show you here pictures. I'll show you a couple of more pictures in the procedure a little bit later. This is from one of our present publications on transeptal punctures. You see, we typically use a radiofrequency needle in combination with everything in this kind of patient that you can employ. Situs inversus, so punctures from left jugular. TOE probe to help with the positioning and the tenting. You see contrast given here. Finally, left atrium is entered, and then finally, and this is a conventional catheter, the catheters are put in the left atrium. Very, very difficult approach. And I would show you how this case was specifically done. I'm just going to exit this and join my Odyssey system. You see that here, hopefully, and you see the recording. So again, this is from the case itself, from the Odyssey platform. So all the magnetic cases are recorded on this platform. And again, here to illustrate the excessive kinking of the aorta, which basically meant that we felt that this way retrograde is not an option. Retrograde procedures in congenital heart disease is actually something that we do nearly all the time. So that would have been my first choice. But seeing that aorta, I thought I would not be able to negotiate this this path. Now, you also see the Assegai continuation here once more, and I'm just going to jump forward and show you again how we did this in the transjugular approach procedure. So here we see a Decanoff catheter that was created or used to create a matrix. And the nice thing here is you have the picture-in-picture display on the Cato RMT system. So that was nice. You can create the anatomy, you can merge adequately, you can orient yourself better on your X-ray reference pictures. And by doing so and mapping everything, you can see that we can create matrix around the entire left atrium that helps with visualization of the radiofrequency needle tip. I use a Baylis system, which has an isolated tip, which is very nice, especially when, as you can see here, the septum is pointing away from you. You don't have to push that strongly. It's not about mechanical pressure. You basically burn through the septum. And that's my go-to technique when I do congenital patients, puncturing through patches and so on. And in fact, because the trick of visualization of the needle tip, as you can see here, or you'll see in a moment, on the Cato system is nice. It allows for zero fluoro even in normal patients. So that's my typical Cato zero fluoro approach for atrial fibrillation patients. But I'm just going to show you a couple of things here. So here the catheter is in the hemiazygos, just so that you can see that reconstructed as well. Here the Decanoff catheter does that right here. And then we put, just because it was relatively easy to mechanically interrupt her AV node conduction, to put a safety catheter in the right ventricle as well, so that we were able to pace her from the ventricle if that was necessary. Here is the RF needle tip visualization. It's a bit hard to see because we fake it as a little catheter. You see it here. There's a little 1-2 on the bottom two screens, and that shows where the needle tip is on X-ray. You see X-ray here as a small call out, and that should be relatively easy. Eventually, it will be moved to a better position. Of course, this is confirmed with TOE. You see, this is already a bit better, but you see the problem. The septum points away, so it's kind of a difficult thing to achieve. So I'm going to jump forward, possibly to this scene, and show you that we eventually managed to get in. Quite difficult to get to the right place and do a safety transeptal puncture. Again, you see here the needle, and then eventually the needle will happen to go in. Massively turning. This is a steerable sheath, which is far too long. I didn't have access here to the short Agilis sheath. So eventually we get the sheath and the needle. You'll see that it's agonizing to watch it even on see it here on the X-ray, pushing the sheath in. Now it's in, and that was the transjugular transeptal. Now, because this is an awkward position, and otherwise you would need to perform the procedure from the neck position, I choose to use magnetic navigation here. So I'm having the magnetic catheter in here. You can see it nicely on X-ray. And then we did the remainder of the procedure on with magnetic navigation. Of course, it's nice the operator sits outside. Let me show you, we mapped the left atrium. She has 2 separate veins for the septal upper and septal lower, and then 2 separate veins for the lateral upper and lateral lower. Normal left atrium appendage, quite a wide ridge here. Of course, remember she has a persistent SVC or bilateral SVC, so there is a big, could say, vein outside here, and that of course makes the ridge very, very thick, and it's quite hard to stay stable. You can see it's easy to move the catheter around. Magnetic navigation is beautiful because it has a soft catheter. The catheter aligns to the direction of the magnetic field. You can see that nicely. It's very easy to reach everywhere, and you don't have to make any awkward hand movements or so on. You just can steer the tip. It doesn't really matter if the catheter here is looped 3 times or where it really comes from. Now, let me tell you that in this procedure, we did pulmonary vein isolation. She is paroxysmal. She had normal voltage. You can see that here, beautiful voltage. And we did a ipsilateral ablation line around the septal pulmonary veins, and then one for the lateral pulmonary veins. I show you here the end result. This is a feature that you see down here that's called ablation history, that shows you how much energy has been deployed via the catheter. It has a number of factors that are taken into account, and in any case, we mapped them, and voltage afterwards were abated in the veins. So that was the first procedure. Unfortunately, this patient had a recurrence. Now, let me just quickly go back to my PowerPoint presentation, just 1 second. So you see it's the same patient, but this time, because the transeptal puncture was such a go and it took forever, we decided to go, and actually it was really a decision on the morning of the procedure, because I feared this redo procedure so much, and I felt that I would have such a hard time going through the transeptal to the septum, that I went through a different approach. I applied an arm approach. So I punctured the brachial artery in this case because her radial artery is too small, and the catheter came up because the first branch was after the kink that I showed you before, and we mapped here the aorta and performed essentially a retrograde approach. You can see here the image integration already. The reconstruction of the right atrium was done with the decanav as before. I mean, you can see here the left persistent SVC. Of course, it's situs inversus, so here is the big ridge basically on the epicardium. But see, that's equal to a vein of Marshall. Okay, so here you can already see we're in the aortic root. I jump a little bit forward. It's very easy to cross the aortic valve. Just a bit later, we'll get into the left atrium. I'm just going to jump forward so that you can see that entering the left atrium is a simple task, very easy with this retrograde approach. And again, catheter is aligning in the magnetic field direction, as you can see here. If there's an obstacle, it's too soft to push anything away. It just won't go. So you can try all kinds of crazy moves if you need to. Now here's the left atrial map. That's the start of it. And then mapping the veins again. And the challenge here was really the ridge towards the left atrial appendage. Now, see again, we can easily reach in the veins here. This is not an issue. The catheter, if you have a brachial artery approach, is long enough. You can possibly loop it 3 times in the left atrium. There's not an issue with that. You can see here we are on the ridge, and we have very big signals on this side. So I jump forward quite a bit because we try to map very carefully all the veins again, and we saw reconnection of the lateral pulmonary veins. So that's what we're starting doing here. There was AF induction and then eventually also termination. Again, the rest of the left atrium is normal in voltage, no other substrate really. She is paroxysmal. She just has a very, very different anatomy. Now, at some point, we felt that ablating on the ridge from endocardial is not doing the trick completely. So we went also into the left SVC, and which is on the right side. It's slightly confusing. You can see again how easy the catheter can go in here. Again, a brachial approach for that. And we have also normal voltage in the right atrium, very easy to move and turn around. And we elected to ablate here in the left SVC as well. I isolated the right SVC equally. Remember, this patient is left atrial isomerism, so there is no sinus node to mention, so there's an atrial escape. Eventually, we cardioverted this patient as she did not convert during any of our RS. And you can see again the ablation history here, ablation from endo and epicardially on the ridge. And finally, that was the end of the procedure. Case is finished. I think I have the X-ray times here somewhere. Not sure, maybe not. But again, the whole thing was done with very little radiation as opposed to the long procedure that we did last time. Now, the transeptal puncture with the jugular approach takes a lot of X-ray, and of course with this arm approach, because you have the image and image integration, you don't have to do this anymore. So let me show you, go back to the presentation mode here and say floor time for this redo procedure was 2 minutes 14 seconds. The procedure was 3 hours long, and we reached everything, and that was really nice. Now, if you think this whole concept further, you could say, you could do this for congenital heart disease, but maybe, what could we do it for more patients? Now, the nice thing about transeptal punctures, of course, and transeptal conventional approaches is that you could have a mapping catheter that you put in your target area, you map around it or you blade around it, and you see kind of the loss of the signals, you see the isolation directly. That would be quite nice. At the moment, of course, we are limited, as everyone is limited, by radiofrequency current. And there is just a very preliminary experience with PFA, and this is very much just in the test phase. It's not experimental. It's not far from clinical use at the moment. And of course, if you think further, you could say, if the catheter would be any thinner, then you could possibly not puncture only the brachial artery, but you could puncture the radial artery, and it would become a true radial approach. So ARM stands for Alternative Access Remote Magnetic Navigation. At the moment, it's really an arm approach, so it's really puncturing up here, but it would be so cool to do it from here. Now, I've done that in PVC ablations, and if you have a man and then the vessel is large enough, of course, you can go for that. In AF, I fear it's a bit, it's not for all comers, let's put it this way. Let me repeat why I think ARM is cool. There is no need for bed rest. It's a shorter recovery time for sure. This patient, the transeptal transjugular approach, had basically hematoma until here that took a number of weeks to resolve. We don't need to do this TSP puncture where the septum is pointing away from us. It's much, much easier. It's an easy procedure. And of course, if you don't have to go transeptal, potentially more operators could perform such a procedure. As you probably know, telerobotic support is very easy on magnetic navigation. You can sign in each other's system, and an experienced operator could join a not as experienced operator to do this kind of case. So let me conclude and say, I think it's time to move a little bit further. I've shown you a very complex congenital case that benefited from this arm approach, made access to the left atrium much easier. And we've done so in many, many congenital patients in the last 15 years, at least in the time that I've spent here at the Brompton. Alternative access, of course, would be cool, and lacks completely the need for pneumothorax exclusion afterwards. It's much safer. You just have large enough vessels in most patients where you can do that. A proper radial approach, I think, is feasible, but ideally would have slightly longer catheters. We're a little bit afraid that the catheters won't reach far enough, or we're not going to reach the final end. And of course, thinner would be better. Thinner would allow us to come to a radial approach with a sheath side that is comparable to interventional coronary procedures. And that would make it easy. All the closure things, all the tricks that they have learned over the last 30 years would be applicable here then as well. So I hope that the hashtag #ARMEP1st will catch on, and well, stay tuned, and I hope that you will hear more from us in the coming months and weeks and months probably. So I thank you very much for your attention, and I'll close my presentation here. Happy to take any questions.
Well, this was pre-recorded, and Sabine agreed to join discussion, but the discussion is planned at the end of the procedure, so we don't have her online. And now the next talk should have been by Peter, but he left because, he's coming, because he's chasing Vivek Reddy. So I hope he finally got him. So it's now your turn, please.
Okay, thank you, Joseph. Okay, so Vivek will be online, so everything is working, okay? Oh, guys, I got from Joseph a very not easy task to answer if the novel structure procedures for LV remodeling, and you know that I'm a little bit crazy by LV remodeling, but after yesterday cases, or the VT cases, everybody who's dealing the VT, I mean ischemic VT or substrate VT, we know what does mean diseased left ventricle. So actually the question is if we can, by remodeling of LV, decrease arrhythmic storming and arrhythmic events. So there's my disclosure. So actually we really need to think what kind of remodeling we are speaking about. Because, for example, if we have really dilatation of the LV, so with increasing end systolic volume index, is clearly worsening the prognosis. So we need to think in which status we can put this lessening of the remodeling when we can stop this process to don't end up with LVADs or heart transplant. So we don't really know what we can get. The problem is that the STITCH trial, which is like 20 years ago, since then, didn't answer properly the question. When the surgeons got the heart in the body actually and lessened by remodeling, I mean aneurysmectomy, and it was comparative study with the patients, with ischemic heart disease, they got coronary artery bypass, actually graft, and then aneurysmectomy plus or minus. So usually they don't perform or they perform aneurysmectomy in these patients. So they randomized these patients and they didn't find any good results. Actually, the aneurysmectomy group was even worse. But when they subanalyzed the patients with effectively lessen the end systolic volume index, that the patient group really create better. So the same question, and this is a very nice slide from Philly group, from University of Pennsylvania group. So actually, this is really interesting. Association between end systolic volume index and less remodeling can create less arrhythmic events. So one of the first, hybrid procedure, I cannot tell you that it's like just transcatheter only, but it's a hybrid procedure. It's so-called bioventrix or revivent system. So what is the procedure about? So we have a hybrid room, surgeon and interventional cardiologist or somebody like me, sitting in the same patient on the other sides of the table. So surgeon make puncture through the left ventricle. Actually, this procedure is designed only for the patients who are with like post-MI, with aneurysm dedicated, ideally MRI or ideally CTI, dynamic CT. They need to have a scar on the septum, so you need to prove that they have a scar on the septum. The surgeon make a puncture from the left ventricle free wall underneath the aneurysm, going through the septum, interventricular septum. So on the other side, interventional cardiologist, I'm standing there and putting through the jugular vein snare close to the septum. So I catch his needle or his like PTCA wire, and I'm wiring the wire through this heart. So actually, again, from surgeon side, left ventricle opened, just minimal invasive, left wall through the septum to the jugular vein, and all this like trolley, like this on this wire, you apply then the anchors. So then you can effectively lessen the aneurysm, exclude the aneurysm, okay? And in principle, you are going through this visible here. So again, going through the left ventricle free wall, going through the septum to the right side, but actually decision how much anchors you can create. So you can go 1, 2, 3 anchors in terms of what you want to lessen. If you want to be effective, it's not working, the movie, so it doesn't matter. So, okay, so it's in principle it's the same. So if you exclude the aneurysm effectively, means that you can lessen the end systolic volume index. And it's visible here, finally. So it's the aneurysm prior to the procedure. And this is, oh, sorry, again, it's not working. Why is it not working? It was going well before. No, it's still not working. At least these 2 pictures, okay. Why is it, what you did?
I just turned off the pointer.
Okay, pointer. Why pointer? I have no pointer here. Okay, so so we have a like left ventricle before and left ventricle after. So you can see the changes. And so we have our series of patients. We did like over 50 patients. And actually we map them, some part of the patients, we map before and after the exclusion. You can see here the left ventricle, right ventricle on the like carto map, voltage map, substrate map. And the exclusion of the aneurysm is very effective. But the problem is that you have some like folder. So you have some space in between, okay? So just we'll show later. So when we analyze our first series of patients, we found that we have less inducibility of VT because when we mapped them before, we mapped them after. So we lessened the inducible of VT very significant level. But it's just a non-randomized trial, it was just feasibility trial. We did without out of protocol, so it was not any reliable data. But you can see here how much we change by this procedure. And actually, if you compare with the stage cardiac surgery data, it's a much more effective method how to create this outcome. So this is European data, which is really similar as our, and this is a case report published by Karl-Heinz Cook, and I would stress here it's not just still this picture only. So it's exclude the aneurysm, and the patient got VT, and you can see here the like the carto map, and the VT exit was going from here. So actually he put the catheter into the folder. Okay, I will show you here, into the folder, and actually he tried to ablate from the channel, from the exclude aneurysm. And remember, we are in the Prague ablation workshop. We did 2015, this guy, it's our guy, not Karl-Heinz guy, our guy. Very similar, look at that. Exclusion aneurysm. Actually, we have a catheter in here, inside, and then we couldn't ablate that, so we used alcohol, and we got alcohol ablation of this guy. And this guy was later on AFib ablation, I mean 3 years after that, well, again, it was maybe last year, or I don't know, last year. It was last year here for atrial fibrillation ablation. So, REWIND trial actually is now finished. ID trial, it's not early, it's finished. So we will see what's happening with, I mean, the morphology, I mean, with the procedure itself. And I can just indicate that it could be anti-arrhythmic, but actually I clearly show you that we still have a substrate, we still have a 3D functionality of the substrate. So we cannot say that we lessen ventricle tachycardia, despite we have some indication that we have less inducibility. Another system, which is another transcatheter LV remodeling system, is transcatheter percutaneous ventriculoplasty acoustic system, which was originally involved to lessen mitral valve insufficiency. But actually the first feasibility trial, regardless on the lessen or not lessen, the volume of the fraction, of the regurgitant fraction, prove that the patients get better in terms of this very effective remodeling, because it's like not annuloplasty, it's submitral, so it's like really ventriculoplasty. So you put anchors, maybe it's visible here, you put anchors to the myocardium, and through the anchors going just wire, and through this wire you have spaces in between the anchors to lessen your force. So then you can cinch the left ventricle, okay? So to effectively, look, it is visible here, by putting the anchors, you lessen the volume and the diameter of left ventricle. It's visible here, the prior and after cinching, prior and after cinching. And these anchors are visible here on the spaceman on this autopsy. There are several examples, actually, what you can do very effectively, and actually the worldwide clinical trials are running. I wouldn't like to go to much more details, but we know that we can, even comparable with this Bioventrix trial, with Bioventrix system, we can really very effectively lessen the diastolic and end-systolic volume index. So again, much better than cardiac surgeons, or maybe better than cardiac surgeons during the time of the stage trial. And so hopefully this study, which is ID trial, which is just starting, could answer if we are able, with this remodeling, again lessen the inducibility of VTs. And this is a question, we don't know. So the most prominent and most experienced remodeling is just this stupid mitral clip procedure, okay, which is really adapted for mitral insufficiency. But actually, co-op study really proved that by this, the first was Everest, it was comparable study, mitral clips versus surgery, but then it was mitral clip done through this co-op study, which really comparing the best medical therapy and the one-to-one randomization. Mitral clip really, in co-op study, really improved the patients. And actually, it's not only reduced hospitalization, but actually it indicates that going good way the mortality data. And actually, they have much better outcome in terms of risk reduction in the mortality base. So actually, it's again something which indicates this kind of remodeling is very effective. And finally, we have some data from the Spanish group that they observe in their patients that they lessen the ventricular arrhythmia, like lessen the ventricular arrhythmia induction, and actually when they compare, they have less non-sustained VTs, they have less sustained VTs, and they have even less ICD therapies in this patient population after mitral clip. So it indicates that might be some option. Parachute trial, actually, again, another system, the parachute implantable device, which is over because cardiokinetics is over, it's done. But actually it was some just idea how to lessen the volume by putting some, just implanting some like parachute, like umbrella to the apex of the left ventricle, like akinetic left ventricle, but it was very passive. It doesn't prove anything, so it was stopped at that time. The last system is a little bit strange system. I need to make you ready. This is really strange. Named contraband. So which is designed. This device is designed to place the stents to both PAs, so left and right pulmonary arteries, with dedicated orifice through the stent. So actually, what does it mean? You lessen the flow through the pulmonary arteries. It means you increase the gradient, but you got, less preload of the left ventricle, left atrium, left ventricle. So you increase the pressure in the right side, so maybe you can get the shift from the RV, LV intraventricular septum. So actually, surprisingly, this study is running, and the implanting procedure is visible here. So it's varying step by step. So first right and left, or right and left, doesn't matter. Hopefully it'll be opening here. So you open the right stent first. It's opening, it's going. It's very dedicated, it's a very easy procedure. Actually, you need to set up where is the landmark, or when is the landing zone. Now the stent will be open, okay? And the same will happen on the left side. Again, now it's open, okay? So actually, the good information for you to be not stressed too much. If we have a bad deployment, we can put a big balloon and we can enlarge this orifice so we can open the artery, the pulmonary artery. This is some example. Actually, this really maybe our patient, I don't know. It's like 6 months after, so it's not just even worsening, it's like a little bit better, okay? And so I wouldn't like to stress you too much with the data because we have no data. There are some patients done. The feasibility trial should be finished in 55 patients, and hopefully in 2 years we will know more. So to summarize my talk is, I would say that this transcatheter LV remodeling is feasible, and time to time, it's really showed that the LV and systolic volume index and diastolic volume index, you can clearly lessen, you can clearly involve, you can clearly improve the patients, you can improve the hemodynamics, you can improve their outcomes, functionality. I have no any answer if this transcatheter procedures can lessen the ventricular arrhythmias. Okay, I would stop here, and thank you for attention.
So now we have to decide if we will have now discussion or if we can continue. Vivek is already online, so we can continue with Vivek and we have discussion at the end as was planned originally. So we can connect to US and Vivek will tell us what is the future of catheter ablation procedure with some conclusions.
Hi, Joseph. Hopefully you can hear me right now.
Can we make it more loud? Can you hear us? Yeah.
I can hear you. Can you guys hear me?
Yeah. Good.
Okay.
We haven't seen you. We were missing you here. We were missing you here. It was very intensive workshop this year. We had also yesterday nice get together.
Yeah, I have to say, I think this is the first Prague workshop in 20 years that I wasn't at, and I really missed it. I heard about both the intensive workshop and the intensive party. So I missed both of them. Well, I really apologize that I'm not there in person. I definitely missed it. If it wasn't an important personal thing, I definitely would have missed it. But anyway, I'm glad to be able to speak on this topic. So Joseph gave me this very simple topic on the future of catheter ablation. So it's a pretty expansive topic. And I think what I'm going to do is try to focus the presentation because in 15, 20 minutes, there's just not enough time to talk about too many subjects. Just know I have a number of disclosures and I will be discussing technology and I'll point out what does not have CE mark approval and what does have CE mark approval as we get to the presentation. Initially, I was going to talk about a lot of subjects. Beyond AFib, I want to talk a little bit about cardioneuroablation as well as about ventricular tachycardia. But I think in the interest of time, I'm going to focus on AFib ablation. But I do want to just make a few comments on other subjects, and maybe I'll do that at the beginning. The first is very quickly, we'll talk about cardioneuroablation. I know that this was covered earlier, so I don't need to say too much about it. But I do think that this is an area that electrophysiologists should focus more on. I think these are patients that are helped tremendously by cardioneuroablation. I think the big challenges for us as a field are, number one, what is the lesion sets that's required? There are lots of lesion sets that are being studied, some that are more expansive, some that are more focused, and I think that we really need to understand what's the minimal lesion set that can help these patients, and particularly they're young patients, so we want to try to minimize the amount of ablation. Second, ventricular arrhythmias. I think this is a really exciting time in terms of treatment of ventricular arrhythmias. Last year was the first time we've had randomized trials published in VT in a long time, and we had 3 of them that were published, SURVIVE and Partita and PAUSE SCD, and all of them showed favorable outcomes, but they were also difficult to conduct trials. They took time to conduct, and I think that the challenges now are to translate these favorable outcomes into procedures that are, let's say, technically a little bit more streamlined. I think that's something that some of the newer ablation technologies like pulse field ablation, potentially the ultra-low cryo, may really help us do. So I think that's very exciting. And the last point I want to make before getting into this talk proper is ventricular fibrillation. There's a lot of new data, and I think some of this was discussed earlier. Michel Hasseger and his colleagues published on substrate mapping of VF, particularly in the hypertrophic cardiomyopathy patients. But and I think that's very exciting. There's also work that Carlo Paponi has been doing recently in terms of trying to substrate map the epicardial surface in patients that have electrical disturbances beyond Brugada syndrome. So I think these are very exciting areas that we need to understand better what is the role. So with that, let me start talking about AFib. I want to cover these subjects. The clinical data, it's important to understand where the field is going. I'm going to talk a little bit about pulse field ablation, since I do think that's the future for AF ablation, a little bit of risk factor modification, and then this concept of pulse field mapping. So let's start with the clinical data. You really can't start talking about AFib without talking about the EAST AFNet4 trial. Now, I think this audience is well aware of the trial, so I'm not going to go to it in details. We know that patients are randomized to early rhythm control or usual care. And I think the key was that rhythm control is now modern rhythm control. Unlike in AFFIRM, we now have dronedarone, and we have a more frequent use of the 1C inhibitors, and we have catheter ablation. It's also important that oral anticoagulation was used in the majority of patients. It was not withdrawn in the ablation patients like happened in AFFIRM. And this is what happened. Remember, the trial was stopped early because of significant improvement in the rhythm control group. Not only were there improvements in all of the, in the primary composite, but also in all of the components. There were improvements in hospitalization, though these did not reach statistical significance. But importantly, there was improvement in cardiovascular death, independently statistically significant, and also improvement in stroke. And this is particularly notable because, remember, about 90% of the patients in both groups stayed on anticoagulation, which means that there's an additive benefit of rhythm control in preventing strokes even when taking oral anticoagulants. I think that's a very important conceptual point that was proven. I think the two other important sub-studies, there were a number of sub-studies that the investigators published, and I think they should be congratulated for that. Two of the more striking for me were this one, showing that the 30% of patients who were asymptomatic had the same benefit. And this one, patients with more comorbidities, the older patients, the sicker patients, in fact, had an even greater benefit. And those that had less comorbidities, of course, eventually do become older and have more comorbidities. So the point is that sinus rhythm is a good thing in AFib patients. By the way, there's another trial called Change AFib, which is a large randomized trial of rate versus rhythm, really focused on dronedarone versus usual care in patients coming in for basically to the emergency room, so looking very early. And there's good reasons to think this is going to be a positive trial. Remember, a decade plus ago in Athena, where patients were randomized to dronedarone versus placebo, there was a 30% reduction in cardiovascular mortality, just like in EAST AFNet4. So I think that this is going to be other data that will be very useful. What about catheter ablation? I think catheter ablation is going to play an increasing role. What we know, of course, about Cabana, and there are a lot of, let's say, controversies about Cabana. But one area that I think there's no controversy is this, which is that there's a 50% reduction in recurrences with catheter ablation compared to drug therapy. And this is on a KM curve. If you look at burden, the data looks even better, and we'll get to that. But I think that what's really sort of pushing people more toward catheter ablation are a couple of things. One is the safety, which we'll talk about more when we get to pulse field. The second is the effectiveness, and we've seen this with a number of first-line ablation trials. And the third are data like this, and these are two trials. I think they're very important. One is the ATTEST trial, which all of you know, these are patients who had failed antiarrhythmic drugs, paroxysmal patients, randomized to radiofrequency ablation or drugs, with the primary endpoint over 3 years of progression to persistent AFib. And as you know, there was a 90% decrease in the progression in the ablation group in red compared to the drug group here in teal. And more recently, the progressive AF trial, which looked at sort of first-line ablation patients, and again, comparing here cryoablation to antiarrhythmic drugs, and a 75% reduction in progression to persistent AFib over 3 years. So it could be RF or cryoablation, basically results in a 4 to 10 times less likelihood of progression to persistent AFib over 3 years. I think this is really important data that's focusing us more toward looking earlier in the disease state. The other one I think is this, which is the effect of catheter ablation on cognition. Now, this is a really nice review article that Jared Bunch wrote, and he looked at the mechanisms by which AFib can affect cognitive decline. One of them, of course, is the obvious one, which is the potential of emboli, macro or microemboli. And of course, anticoagulation is critical here. But the other one I think that we're just starting to understand is the impact of cerebral perfusion or lack thereof on the brain, and the potential impact that maintaining sinus rhythm has. This is a propensity match analysis from the Korean database. And there are now, by the way, several databases, the UK database, others that have looked at this. But what you see is compared to medical therapy in AFib patients, if you look at ablation, there's about a 27% reduction in progression to dementia. And by the way, look at the time horizon here. This is 10 years. So this is something that accumulates slowly over a long period of time. By the way, I think it's unlikely we'll ever see this in a randomized trial just because of how long it takes to see these changes. If you look at the type of dementia, there's a reduction in both Alzheimer's dementia and vascular dementia. If you censor for stroke, meaning take away the embolic events as far as we know them, there's still an improvement. So suggesting the improvements in non-vascular dementia. What is the mechanism of this? Well, it does seem to be ablation success. You see, patients where there was ablation failure did not show benefit. It's when there was success that there was a benefit. So it's maintaining sinus rhythm that's important in reduction of dementia. What is the mechanism of this? Well, this is some direct data looking at cerebral perfusion or cerebral hyperperfusion using phase contrast MRI. I'm going to show you two trials. The first is this one, the Aegis Reykjavik study, looking at over 2,000 patients undergoing phase contrast MRI. And what you see, and some patients had no AFib, some patients had paroxysmal, and some patients had persistent. And what you see is the patients compared to no AFib, if they had paroxysmal or persistent, have less cerebral blood flow. The second is this smaller study, 44 patients undergoing cardioversion for persistent AFib. And they separated these patients into two groups, those that stayed in AFib and those that went to sinus rhythm after cardioversion. And here's what you see. This is before cardioversion. This is the brain contrast MRI. If you stay in AFib, meaning no difference with cardioversion, basically there's no difference here. And this is what you see, basically no change. In fact, it gets a little bit worse. On the other hand, those that went to sinus rhythm, you have an increase in brain perfusion. And this is something that's now being seen in multiple studies. And I think this is going to be a very important point. The other data, of course, is the AF data in heart failure patients and HFrEF patients. We know about multiple smaller studies, including the larger Castle AF trial, which showed a NNT of only 6 for improved mortality. Basically, a 50% reduction in mortality, improvements in ejection fraction, 6-minute walk, VO2 max. I mean, I think the question is, I think there's very little doubt that HFrEF patients will show improvement. I think the key is, how do we do these procedures in HFrEF patients who are oftentimes tend to be sicker, and do them very quickly and very effectively. HFpEF patients, there's the Cabana sub-study. 35% of the patients in Cabana had heart failure, of which the majority, 90%, had preserved ejection fraction. And even on the ITT analysis, there was improvement in mortality with ablation shown here in red compared to drug therapy. Now, this is a secondary analysis of an ostensibly negative trial. So we need to see this prospectively. And there are some trials that are ongoing or being planned. There's also the RAFT AF trial, but I think that's just an underpowered trial, so I won't get into that. The final point I want to make with regards to AF ablation is this. You know, I think we as a EP community have been very strict in terms of what is success. And I think that's good in some ways, but it also, I think, diminishes the potential role to our cardiology colleagues. And I think many of you have seen this. Of course, you all have patients like this. You have the amount of AFib before ablation procedures here, and everything looks good. But this patient actually had a recurrence. There was a couple of minutes episode of AFib at this time. Is this a failure? Well, of course, in any Kaplan-Meier curve, this would be a failure. But this is a dramatic reduction in AF burden. This is the That's a single patient. Here's data from Circadosh showing that if you look at time to recurrence on KM curves, the success is 50%. But if you look at AF burden, it's about a 99% reduction in AF burden. And this is important. We know from the Castle AF sub-study, if you look here, when the AF burden shown here on the x-axis drops below 50%, the mortality becomes quite low. This is true, by the way, in the ablated group. It's not true in the drug group, mainly probably because of the toxicity of the drugs. Similarly, this is a study looking at patients who have implantable devices, 39,000 patients. Here, the investigators looked at AF burden over the first couple of months, and then based on that burden, they separated the groups and looked at subsequent mortality over 3 years. And here's what was seen. The more time you have AFib, the more burden there is, the higher the mortality. So I think this is something we need to sort of discuss with our colleagues, explain to our colleagues that reduction in AF burden is the real answer. Now, how do we actually demonstrate that? I think this is a more complex question because I think it's unrealistic and probably unreasonable to put implantable loop recorders in all of our patients. I want to move on here to, let's see, pulse field ablation. You've had a number of talks and seen a number of presentations on pulse field ablation about the some degree of tissue preferentiality to spare surrounding tissues. We've seen studies like this. This is from Piaget and Hubert-Cochet showing that in cryo and RF ablation, as well as pulse field ablation, yes, you ablate the atrial tissue, but in cryo and RF, you also ablate the esophagus in about 40% of the patients, and you don't see that with pulse field. I think this is the most dramatic data and the most impressive data. This is some of our first in human work using the pentaspline catheter, and this is delayed enhanced image showing the ablated tissue. We use this, we have a series of publications with Peter and Piaget and also Ante Anic showing the success in patients undergoing ablation for paroxysmal AFib. This is a smaller study in patients after PVI where we ablate the posterior wall, showing, again, good durability with remapping and good success, albeit, again, in a very small number of patients, 25. But based on this, there are a number of large randomized trials that are ongoing. The Advent trial is done enrollment. This is randomized trial in paroxysmal patients of pulse field versus thermal energy. This is going to be reported likely later this year, perhaps ESC or American Heart. There's the Advantage trial, which just started enrollment, very large trial of persistent AF patients, PVI plus posterior wall. It actually, as I said, it has already started enrollment, so this would be a good trial. And then there's the BEAT AF trial, which is a European randomized trial of pulse field versus radiofrequency in both paroxysmal and persistent. And the enrollment I know here is ongoing. So I think that's very exciting. I think one of the challenges we're going to have is how to deal with all these various technologies. We now have a number of technologies. There was the pentaspline catheter, which I already talked about. There are other similar basket-type catheters in trials around the world. There's also these circumlinear catheters, including the pulsed AF trial, which is a non-randomized study that reported its data at ACC. There's other designs like the Globe catheter, which is going to start clinical trials in the U.S. later this year, the PFCA catheters, and then there's the focal catheters. This system, the Galaxy system, the Affera system, which I know you've just seen cases of this that can deliver RF and PF, as well as other focal catheters. It's important to know that of these, none of these are FDA approved, but 3 have CE mark approval. The pentaspline catheter has been approved for about 2 years now. This was approved last year, and the Sphere catheter, the lattice tip catheter, this just got approved in Europe literally like a week or 2 ago. So I think certainly in Europe you'll have a number of options, though in the US we're still waiting. I think the one point I'll make is that there are only a few examples where there's actually remapping data. And actually now we have remapping data on the globe also. The majority of these catheters do not have remapping data. And I think that's a very, very important limitation. The acute clinical data always looks good in all these catheters because pulse field just wipes everything out and really doesn't mean much. It has to be remapping data. Without it, I don't even know how to interpret the effectiveness of these catheters. Ideally, they're clinical remapping studies, but at least I think studies have to report what is the remapping results of those patients that came back because of clinical recurrences, because that gives you a good idea of what's happening in the full cohort. Lots of challenges. If we look on the safety side, so far things look good. No esophageal damage, no PV stenosis, no phrenic nerve palsy in this initial analysis, though I should note there was transient phrenic nerve paresis, meaning it resolved before the hospital discharge, and there's at least one case report of phrenic nerve palsy. So I think the phrenic nerve damage can happen, and we need to understand that better. There are other challenges. Probably the most important one, I think, is how much ablation is enough. And I think we need to balance success with mechanical dysfunction. I mean, all of our trials at this point have a primary endpoint of success. None of them look at the amount of atrial tissue that we're taking out of the equation. And that's something I think we need to change in terms of how we think about this. The effect on autonomic function, these are two studies, one from Joseph's group and one that Peter and I performed looking at the autonomic effect. I think in the interest of time, I'm not going to go through this in detail, but what's very clear is that pulse field has minimal effect on the autonomic ganglia, unlike thermal ablation. What is the impact of that? I think we need to better understand that. So I'm going to skip these slides here. The other one is coronary arterial spasm. This clearly occurs. It can occur with any technology, but it seems to occur pretty reproducibly with pulse field ablation. We published this paper showing that remote ablation, meaning a PVI or posterior wall ablation, really does not cause spasm, and we shot the coronaries. It doesn't mean it can never cause spasm, but it doesn't routinely cause spasm. But adjacent pulse field, so if you're ablating right next to the coronary, yes, you can cause spasm, and yes, you can attenuate this by giving either intracoronary or intravenous nitro. So again, I want to emphasize, with PVI or posterior wall ablation, you don't cause spasm. You cause spasm when you're next to a coronary, almost routinely subclinically, and sometimes it becomes clinically relevant. So, and we can also prevent this by using intracoronary IV nitro. So the question is, there's lots to understand about this. How often will spasm become clinically relevant? The real answer is we don't know, but let me show you a publication. This is from a single center, 108 patients who are using the pentaspline catheter. In 6 of the patients, they performed CTI, and ST elevation was observed in 2 out of 6. In one patient, there was ST elevation, they gave IV nitro and resolved. In the other patient, this is what happened. You can see with after the last lesion, 4 minutes later, you see ST elevation in the inferior leads. Then the blood pressure drops. 8 minutes later, you're starting to see AV block and PVCs. And then 9 minutes later, there's a VF arrest, requiring CPR, DC shock, and IV nitro. And the patient did well. But the point is, really, how often does spasm occur? If it really occurs 33% of the time, that's a problem. We'll probably want to be giving nitro prophylactically. If it occurs 1% of the time, then I think we'll have to make a decision. Is it better to give it prophylactically or expectantly if we start seeing ST changes? What is the best strategy for dosing? I think we still need to figure that out. Will a focal catheter also cause spasm? Remember, with a large catheter, you have a wide field. If you have a focal catheter, will it cause spasm? In preclinical studies, the answer is yes. In clinical studies, we need to study this. And finally, are there late coronary effects in terms of late loss of caliber of the vessels? And this is something we need to understand better. You know, as I talk about all these potential complications, you may be thinking, well, is PFA too complicated? Well, I just want to show you this. This is given to me by Steve Mickelson. This is a high-speed camera that you're going to see of an RF lesion. And as it runs, this is what a steam pop looks like. And that's the kind of damage that you cause with a steam pop. I'm just going to let it run again because it's just such a dramatic thing. So just remember, that is what we currently do every day. I mean, not steam pops every day, but the potential every day. You know, I'm sort of losing track of time. Do I have any more time, Jacob? Joseph, how much time is left?
You can go, Vivek, okay? Just 5 minutes.
Joseph, are you there? Is anybody there?
Can you hear me, Vivek? Can you hear me?
Yes, hi, Peter. Yeah.
Okay?
Yes.
So you have 5 minutes, okay, more, okay?
Oh, 5 minutes. Okay.
Okay.
That's perfect. It'll give me a little bit more time to get on my soapbox.
Thanks.
So I want to talk a little bit about risk factor modification, where I see the future of this. This is I think a review article from Prash Sanders, who's done a lot of really nice work in this area, as all of you are aware. But what is the actual clinical evidence with regards to atrial fibrillation? It's a little bit more limited, unfortunately. Alcohol, absolutely. There's now randomized data that all of you are aware of, so I won't go into this, that abstinence is very important in terms of reduction of AF burden. But there's no data in terms of glycemic control, smoking, or hyperlipidemia. This is not to say that we shouldn't be encouraging our patients to stop smoking and reduce lipids. But the point is, there's really no data on this in terms of atrial fibrillation. What about blood pressure? Again, really no data. What about sleep apnea? Well, I think you're aware of this. There's relatively little randomized data, and the only randomized data has been pretty negative. This is looking at CPAP in sleep apnea patients who are undergoing ablation, and whether you use CPAP before or after ablation, there was really no difference in AF recurrence. The same thing if you look at the AF burden. Now, we should note that larger CPAP trials are ongoing, so we should reserve final judgment, I think, until we see those. But I guess the point I'm trying to make is this: not that CPAP may not help some patients, because I think it does, but in the past, we actually had a program of checking whether or not every patient in our AFib clinic would have sleep apnea, and then we'd refer them to the sleep doctors. And we basically stopped that, because until I see some data showing improvement outcomes, I have other stuff I need to spend my time with these patients on. But I think obesity is an area that's a complicated one. There's a lot of preclinical and mechanistic data that indicates that obesity, and particularly epicardial adipose tissue, has an important impact on the myocardium, direct effects, paracrine effects, that through inflammation and other cytotoxic effects leads to atrial fibrillation. The data on this, unfortunately, again, is less optimal. I'm not showing the first randomized data that Prash showed, which showed a reduction in AF burden, because I thought that was a very nice study. But the only other randomized data that I'm aware of is, the other major randomized study, because there's some smaller ones, is this SORT AF trial, which looked at 3 centers randomizing paroxysmal or persistent AFib patients who are obese to either AF ablation or AF ablation plus basically weight reduction. The weight reduction group did indeed lose more weight, 5 kilograms versus 1 kilogram, but no difference in outcomes, no difference in AF burden. On the other hand, there was a difference if you look at success. So those patients that lost some weight, shown here in teal, did better than those that frankly gained weight. But so the answer seems to be that, yes, it would work, but we just have to get better weight reduction. And so what's the future? Well, it may be this. It may be the newer classes of agents, the GLP-1 agonists like semaglutide or tirzepatide, which really seem to be quite effective in terms of weight reduction. And these are, again, weight reduction trials. So perhaps strategies like this, when applied to our patients, may improve outcomes. This remains to be shown. But the one other area I would argue in terms of risk factor modification is modulation of autonomic tone. We know from studies like, there are different ways to modify the autonomic system. The ones that seem to be most relevant, the data for AFib, I'll show you here. One is renal denervation. We know from the ERADICATE trial that adding renal denervation to PV isolation improved outcomes substantially, a 43% reduction in AF recurrence. This is a meta-analysis that we published with 700 plus patients. And overall, if you look at this, when you add renal denervation, you improve AF recurrence by 32%, meaning reduce AF recurrence by 32%. So I think we need further randomized trials here. This is a trial we're looking at where patients who are undergoing AF ablation don't have refractory hypertension, just have some degree of hypertension, randomized to renal denervation using this ultrasound catheter, which I think is very nice because it's highly effective in preclinical studies. And so we'll have to see what trials like this show us. But I think the other really exciting area is transcutaneous autonomic modulation. Some of you may be aware of the work from the Oklahoma group looking at low-level tragus stimulation. There was the TREAT AF trial, which I think sort of unfortunately got lost in the pandemic. This was published just before the pandemic started, or as the pandemic started. It was a really nice sham control trial looking at paroxysmal patients randomized to either trachea stimulation or earlobe stimulation, which is basically sham. That does nothing. And what was shown is in the sham group, you have an increase in AF burden over time, exactly what you'd expect. But in the trachea stimulation, not only did it not increase, it actually decreased. And this is a statistically significant result. There was also reduction in, excuse me, in TNF alpha, consistent with this suppression of anti-inflammation. So I think this is a very exciting area that needs to be studied further. And what's I think the other exciting area, it may not just be this, there may be other approaches like median nerve stimulation. There's at least one technology that I'm aware of, comes in a wristband that's being studied to affect this. And I think what's really exciting to me is the idea that transcutaneous stimulation could interact with AF ablation. And so if we look at the progression of AFib, you have paroxysmal and persistent, but of course before this, patients oftentimes have PACs before they become paroxysmal. And of course, there are patients who undergo ablations who have recurrence. So if we look at this life cycle of AFib, right now, what are we doing? In this population, patients who are typically receiving antiarrhythmic drugs, then catheter ablation. Of course, increasingly, some patients are receiving primary catheter ablation. But you can imagine transcutaneous stimulation approaches being used to prevent post-ablation arrhythmias, to improve the outcome of ablation. They could be used in these patients to reduce the AF burden in paroxysmal patients, or perhaps reduce AF recurrence in patients undergoing cardioversion. And probably the most exciting is these patients who are just starting to have PACs before we would even consider using drugs or catheter ablation. Perhaps you can reduce the progression of AFib in this population. I think these are the really exciting areas. So I think with that, I'm going to go ahead and stop see if there are any questions. Thank you very much.
Okay, thank you, Vivek, for a very elegant overview of all different topics and technologies. We have also Sabine on line, let's say, and we see both of you. So maybe we start the discussion as, for 3 lectures together. Any question for Sabine?
Let me maybe first also say hi and say that how unhappy I am, like Vivek, that I've missed the party. Okay. And it's such an honor.
Don't worry, there will be in the future some more parties. Don't worry.
Exactly, we'll count on that. Perfect.
Hey, Sabine, it's Peter Nozel. Hey, it's a very nice recorded case, very nice introduction of the radial access. So I have a question for you, regardless on magnetic navigation, because we just have no navigation, right? So actually, without navigation, would you see feasible to change our catheters, to change our whatever tools what we are using, to get really to switch to the radial access or brachial radial access? What do you think? Can you stress it?
To be honest, I had this discussion already with a number of colleagues, and the beauty of doing this arm approach, we call it arm because it's kind of clear that's kind of somewhere on the arm, can be radial, can be high up, is very, very simple. If you only steer the tip of a catheter, it's very, very simple. You're pointing in the direction, you have enough magnetic experience to know how easy it was to get the catheter everywhere. And it's just I'm trying to push what the magnetic system can do very easily for you. It really doesn't matter where the catheter comes from. And of course, also that catheter needs to be slimmer, ideally needs to be PFA, or at least a range of configurations of the tip. The thinner, the better. And then we thought, okay, but it still limits us to centers that have the magnetic system. Of course, the magnetic system is expensive. It takes place in the lab and so on. If you think how easy our coronary colleagues have absolutely no stress to get in the left ventricle, getting retrograde in the left atrium, negotiating the mitral valve is not that easy. It's something with magnetic navigation. Again, I do that all the time in congenital heart disease. That's not difficult. And the fact that the catheter is so soft, is so forgiving, that you basically poke around until you made it. I think that is not so simple, especially if you don't have direct imaging. So if you wanted to have an ICE catheter on the tip of that catheter to help you seeing the valve, because you need to see it when it's open and then you slide in. I think it's a lot of innovation asked from to make that a mechanical only system. It's probably not impossible, but it's, the nice thing about this retrograde approach is that you can get rid of the transeptal part. If you think about why haven't interventional cardiologists not taken up the single shot devices in greater numbers and done, as it was predicted, that cryoballoons or any single shot would be in the hands of non-EP doctors, would help us solve the epidemic of AF patients hitting us. We're under-treating. There's so many more patients than we can treat. And the problem that I see is training people in transeptal punctures and doing that safely. But they're already 3/4 of the way to the left atrium, right? If we would manage to get them into the left atrium from a radial approach, we would take all of their expertise and just get them into the left atrium. I think it would open the field and making simple ablation. I'm not talking about advanced, persistent, massively enlarged atria and so on, but just the simple paroxysmal AFs that we would only do PVI in. I think that would be a great technology if we would manage that.
So
the short answer is not yet, but magnetic navigation makes it very easy.
So discussion, actually you stressed very nicely. Actually, what we used magnetic navigation as third axis for, mainly congenital, okay? And actually there's strange anatomies. Actually we were approaching many times LV, transaortic LV and mitral. But the problem is they need to improve, because we still need to have more than contact, okay? We have a contact, but we need to have more than contact, okay? So maybe the technology need to improve, even the current one, okay? Even current stereotaxis need to improve. And actually, I think I like it, because you stress very nicely. The patient can move immediately. They can, like, same day discharge with a glycate, because in the US everybody is stressed by hospitalization. So same day discharge is the target. Even no COVID doesn't matter. So I like it. People, what do you think, people?
Well, I think generally it's interesting, but it would require a lot of advancement, as Sabine described, because I cannot imagine that you can do it today without any magnetic navigation or things like that. On the other hand, we see now tremendous simplification of the ablation procedure with pulse field, as both we have experience in Czech Republic. Just to remind you, we did last year more than 1,300 ablations more, and it was mainly because we started to use in 8 centers pulse field, and both our centers did one-fifth of the worldwide production or let's say volume of cases within 1.5 years. So this was only possible because of simplification of the procedure, because you can plan procedure every hour. You can do one procedure every hour. So it's really like if you plan pacemakers or ICDs, implants. So I feel that it's really interesting concept. But it would require a lot of development and maybe some completely new ideas how to apply energy or what kind of energy, or maybe pulse fields should be used in this way. But it's far from potential clinical use, I would say, beyond stereotaxis use, as you nicely show.
Yeah. Let me make quickly comment and say what I've seen now in my small experience here locally is, of course, for normal procedures, let's keep the atrial fibrillation aside. So SVTs, PVCs, everything that you can save, cannot easily solve with 2 catheters. It's really easy. And patients, I give patients, of course, I offer them to have this ablation. And I'm sure that you also have seen patients who come to the outpatient clinic and say, so doctor, how do you actually do it? Can you do it from my arm? Yeah. And I always said, I would love to, but I didn't. And it was really a matter of my COVID experience on intensive care to say, oh, the vessels are actually bigger than I thought. So then that's how we started it. But patients actually are super happy about this. You know, I think patients will vote with their feet to a certain extent and say, oh, if I can get it done from my arm, ideally radial, then I'm going to go for that. So that's a small factor. It's not solving the world crisis of atrial fibrillation or catheter ablation, but I think if we keep in mind that radial access for coronary intervention took 30 years to come into the kind of mainstay, and that's now over 90% of the procedures are done from a radial approach. When they started in 1989, there was a handful of enthusiasms and probably some, I don't know, nerdy people like we EP people normally are, right? We're a bit nerdy. And doing this and trying to lead this. This is going to take a time to kind of catch on, and I completely agree with what you said about PFA. The nice thing about magnetic navigation is you get the catheter everywhere. It's not entirely sure that you always do a great lesion. And that's exactly the shortcoming. So if the lesion would get better, and I expect that from applying PFA through a magnetic catheter, I think we're going to have something that is really competitive in the way, and then access doesn't play that role anymore, and contact doesn't play that much of a role anymore, because we know that's going to be low. And again, I hope that I will be continued to be invited to show the progress on this, and maybe with thinner catheters, maybe with visualization of the lesion. A couple of startups that you're all aware of, seeing when you have applied enough energy to see that the lesion is good and durable. So that would be a big step forward.
Any more questions for Sabine? No. Peter's usual talk. Any question or comment before you think about? I can maybe have comment, because I mean, you can do probably hemodynamic improvement, or you may do maybe even prognostic improvement. But if you still have the arrhythmogenic tissue on site, I would not expect that much, let's say, decrease of risk of monomorphic arrhythmias. You can maybe expect some decrease in some arrhythmias which can be triggered by heart failure or by, let's say, this advanced remodeling, but probably these monomorphic VTs, I doubt that we can get rid of. And these patients are quite sick. And as you know, our experience with this radiotherapy, you can treat maybe this arrhythmia, but they will die anyway. Half of the patients died within 2 years. So they have limited prognosis. So this is just, I put it like provocative title, but I don't believe that we can just by some anti-remodeling procedures really decrease the number of VTs.
So yeah, it's a very good comment. Actually, I was really surprised when you asked me to make it, because I did several talks for VT for VT conference, whatever. So actually, we have enough data, what you just mentioned. For biometrics procedure, which is exclusion of the aneurysm, the substrate stayed there. Okay, so you exclude, you have lessen volume, you improve maybe anatomy, you improve volumetric and ergonomic situation of the ventricle, but the substrate is still there. And we really prove, I mean, Karl-Heinz Cook in Hamburg, and we here in Homolka, we proved that we have still the problem. So we have 2 patients within the group of probably less than 100 patients, maybe 150 patients. So we proved that they still have VTs, right? So, but on the other hand, I really want to stress that interventional procedure can reach the better, sometimes better result than surgeons, which is I mean, again, provocative, but actually we need to get something in between I mean, medical therapy, CRT, maybe CCM, and then nothing, right? Like
that's the same like with atrial fibrillation. I mean, we are getting better results than surgeons do with epicardial ablation or a thoracoscopic approach. I think this is clear.
Okay.
No, any question, comment? No. So Vivek, it's your turn. do we have any comment for Dr. Reddy? Any question?
I have a question for Vivek, okay? When you stated the spasm, okay, because we have now era that actually we have pretty much expanding the procedure, okay? We have a really nice calculation, actually, Pepa just mentioned the numbers, okay? In Czech Republic, small country, right, like big numbers. And so I mean, spasm, okay, most of the spasms are really subclinical. We have some evidence like 1, 2, 3, 4, 5, 10 patients with significant changes, ST elevation, clinical relevant, okay? But we must have much more spasms invisible, okay? So what is clinical evidence for you? What's your, so actually if we can add, for example, like atropine in the beginning of the procedure to lessen the need for pacing, and it's effective, okay, effective. So do you think that the nitrates dosing pre-procedure is effective or is solving the problem?
Yeah, I mean, I feel like you're like a plant for this question. I think that yes, I mean, I think that we don't fully understand the dosing yet. I think we're working that out. I think the question is going to be how often do you need to pre-treat? I think your question really is, look how many patients are being treated and we're not seeing that many clinical spasms. Is this something we really need to worry about pre-treatment? I think that's your real question, Peter. And I guess the answer I would say is this. It's only when you have the really bad case that it affects you in terms of how you think about what you should do. I mean, look, the majority of the time, it's pretty clear that we can get away with it, that the spasm either didn't occur or probably more likely occurred but was not critical enough. The problem is, let me just ask you, I'll flip the question around to you. I think we would all agree that if in 1 out of 10 cases when you ablate next to a coronary, you had a cardiac arrest, then we probably want to pre-treat. I think we can all agree on that. If the answer is 1 in 1,000, well, then maybe we don't need to pre-treat every patient. Maybe we should do it, again, carefully pay attention to ST changes during ablation and give nitro as needed. But the question is, what is that? The answer is going to likely be something in between. It's not going to be 1 in 10, and it's not going to be 1 in 1,000. It'll be something closer to, my guess is 1 in 100, okay? It could be 1 in 30. And I guess my question to you is this. If 29 cases you do this and you have no problem and you're not even thinking about it, in the 30th case, the patient has a cardiac arrest, and we all know how, critical a cardiac arrest can be in terms of the stress level, the potential lethality, et cetera. What is your cutoff?
It's, it's a little different situation, right? So you put a very provocative question. So
so is it 1 in 100, 1 in 30, 1 in 350? It is a provocative question. I don't even really want to answer.
Can I intervene? And I would say, I mean, I saw really one clinically relevant spasm with ST elevation with no sequelae, which resolved within few minutes after administration of isosorbate. In hundreds of cases we did. So I don't believe that if there is a subclinical spasm which does not create any ST elevation, that this can trigger really ventricular fibrillation or cardiac arrest. That's why I believe that should be some really sign of ischemia on ECG, which is very sensitive for that. So if we get information from register that there are really more cases or there are cardiac arrests, then we can discuss what is a level of trigger. But if this is really like anecdotal observation, then I think we are maybe worried too much. Yeah, but maybe not.
But you know, Vivek, actually, here is the different situation. We have over 1,200. Okay, 12,000. We have 12. No, worldwide, 12,000 procedures. Okay, and actually, in Czech Republic,
but hold on.
It's about like 15.
But Peter, don't conflate these things. We may have actually 15,000 PFA procedures, but the majority of them did not include ablation next to a coronary, right? The majority of them were PVI and posterior wall. It's the exceptions that are ablation on the CTI or mitral isthmus. So I think we just have to be a little bit careful. Let me just end with one last story. This is not even about pulse field. This is radio frequency. I've done, probably hundreds of cases of mitral isthmus ablation, right? Haven't seen a problem. About a couple of months ago, I had a patient who came in, mitral isthmus lesion. I only gave one lesion. No, that's not true. I gave 2 lesions, the total amount of RF, and this was from inside the coronary sinus. And as I was sitting there talking to the fellow about how one has to be careful about the coronary, the patient fibrillated. Okay, fibrillate, fine, cardiovert, right? Cardiovert, defibrillation, nothing. 7 or 8 shocks later, patient is still in VF. We're doing chest compressions, trying to shoot the coronary, trying to get vascular arterial access and everything else in this AFib case. Half an hour later, we end up putting in cannulas and put the patient on peripheral bypass, okay? Because he's still in VF. We finally shoot the coronaries. They're completely spasmed. Well, it's spasmed down at that left circumflex, and it turned out to be a left dominant system. Eventually, the patient came back. Eventually, the patient was actually able to leave the hospital. But I got to tell you, a case like that changes how I think about the rare complication, especially when we're talking about doing these procedures earlier and earlier in the disease state. So, look, I'm not telling you that means that with this anecdotal case, we should be giving nitro to everybody. I'm just saying we have to be a little bit more humble about what we think we should do. I don't know what the answer is yet.
So you would stop pulse field ablation, right? After this, if you have
no.
Perfect.
First of all, that was an RF case.
Very nice.
No.
I understand. RF case and PFA. Pepa stated that he has PFA cases, right? So we have actually. I have in my institution now, we calculated 1,100 cases. And actually, we might be lucky, but every single potential spasm, actually, we know that we have spasms. No any clinical evidence spasm. No any.
No, I guess what I'm saying is, this is not an indictment of pulse field. I hope that's very clear. You keep talking about 1,200 cases. Those are 1,200 cases with PVI and posterior wall. It's a subset that had mitral or CTI. What I'm saying is we should probably consider giving nitro prophylactically more often than we do. That's all I'm saying.
So let's set up the dosing. Okay.
It's also interesting what you mentioned, that we may have differences between unipolar and bipolar, between different tools, because we have some experience also with Affera, which is different from Farapulse, obviously. So it's really, we are at the beginning of completely new era. So we have to study all these side effects. We have to record them. we have to find out maybe some need for prophylactic administration of drugs like we administer typically atropine, as Peter mentioned. So, yeah, I agree. I don't want to somehow dismiss that this is important topic, but maybe, you know, every discussion with people who do not use pulse field is, and what about spasms? This is very high risk, you know.
Well,
so
I
this
agree
is
with
typical.
that.
This is quite typical. So.
No, I agree with that. I mean, I think we have to keep this in context. I 100% agree with that
Vivek,
point.
after your comment about your RF complication, I would stop with RF. Perfect. Okay.
I knew you'd say something ridiculous like that.
Yeah. Maybe I can have a small comment as well. I think this is actually it's a matter of rare events and then a 33% event rate. That's a different thing. So this kind of experience that Vivek described has been published. Actually, I just left Hamburg, and that is now 15 years ago, and the same thing had happened there as well. And the patient was not recanalized, was not acted as quickly, and ended up in the end with a reduced LV ejection fraction and an ICD because of VTs, and had 2 more VT ablations, and only came in for paroxysmal AF, and someone decided that the lateral isthmus line was important, and that was added, and that started the trouble. So I think there's a difference in kind of frequency of these kind of things, and I completely agree that with PFA, I see it like still a bit of an untamed or unresolved new energy source. There are so many variations in the waveforms, the energy applied, the duration, everything else. I mean, if you remember Fred Whitcomb shooting on the coronary without any impact, kind of in the initial animal data that he showed us.
That is again what we always discuss, that pulse field is not, there is no class effect, you have to study every platform, every energy, let's say, every generator differently, because this is nothing uniform, you know. So this is important message for everybody. So it's not like RF or cryo, where you have a very limited number of differences where you can, or variables we can change. But this is completely different story. But we are, I believe, and I hope that all believe now, that we are at the beginning of a new era in catheter ablations with pulse field, and especially for complex arrhythmias like atrial fibrillation and ventricular arrhythmias. So saying that, I think we have to close our meeting because we had a plan to finish at 1:45. We are a little bit over, but I would like to thank to both of our remote speakers, I would say, and I hope that we will see them next time. I would like to thank all speakers here and operators, and also all participants for coming, for sharing their experience in discussions, for friendship. And I would also like to thank to sponsors, because without their help it would be impossible or very difficult to organize a meeting of such a scale, mainly Abbott, Cardion and Medtronic, which are our platinum sponsors, but there are also some others like Biosense Webster, Boston Scientific, Medion, and also to company which organizes all logistics, which is CCL company, and namely to Hanna Klimentova, who was the main sort of organizer of this meeting. So thank you again to all of you, and I hope that we will meet next year or in the future again in Prague in spring for next edition of this meeting. And for all of you who are here, safe trip home, and stay healthy and come next year again.